bleeding is classified as 4 types. Stage 1 is patient is asymptomatic, only warm or shunting on Doppler. And the 2 and 3 are intermediate stage. And in the stage 2, AVM is getting enlarged. And the patient feels the pulsation, thrill, bleed, and also the tortuous veins. And the stage 3 is the destruction phase. You can see the dystrophic skin change, ulceration, and sometimes bleeding, and patient feels pain. And the stage 4 is the decompensation phase. So the patient is present with cardiac failure. And when should we treat the AVMs? In general, Schrödinger stage 3 and 4 lesions should be received treatment because the patient have some kind of the symptom. However, whether lower stage AVMs should be treated is still up for debate because the embolization of AVM is not always safe. Sometimes we encounter complication. But another important issue is that almost all AVMs at Schrödinger stage 1 eventually progressed. And with nearly half of them become the stage 3 and above. And moreover, in the stage 1 and the stage 2, it's easier to treat compared to the stage 3 or 4. So now it's open for the consideration when we treat the AVM. And next, I'd like to talk about the anatomy and especially focus on the nidus. Most reports have traditionally described the angiographic findings of AVMs in terms of the feeding artery and the complex network of arteriovenous shunt, referred as the nidus, and drainage vein. And also the target of the embolization is the nidus, of course. However, AVMs are so diverse and diffuse in nature. So whenever I treat AVM, I ask for me, where is the nidus? Where is the nidus? So this is a case of AVM at the forearm. And it's angiography from the axillary artery. You can recognize the nidus. Where is the nidus? Sometimes such kind of angiography is not effective to recognize the nidus. So that we need the selective angiography or the direct puncture angiography to recognize the vascular architecture of the nidus. And this is a selective angiography. So this image is better to recognize the nidus. Maybe here's the nidus. Many feeding arteries shunting to the vein. Also around here nidus. So in the one AVM, there are several nidus. So we need some kind of same category to talk about the nidus. And this is a very famous paper from the Samson Medical Center, Korea. Dr. Yasudo classified the angiographic findings of AVM in the 4 type, 4 type. Type 1, type 2, type 3, type 3B. Its findings are very important for us to talk about the nidus. And also we treat the nidus based on these findings. And so recently Dr. Yeeks also proposed the Yeeks AVM classification system. And this is a little different from the Samson classification. So we must use Samson classification or the Yeeks classification to talk about the nidus. So usually in my university, we use the Samson classification. And type 1 is the direct arteriovenous fistula. In the original paper, they say that the number of the artery is less than 3. So it is it's looks like the AV, not AVM, AVF, AV fistula. And in the type 2 is the arteriovenous shunt between the multiple feeding arteries and the dominant outflow vessel. So very fine, neuraminous many fine arteries shunting to the dominant outflow vein. And the type 3A is a small fistula between the multiple arteries and the multiple veins. And type 3B is a large fistula between the multiple arteries and the multiple veins. And so here is the nidus. Nidus is the shunting between the artery and the veins. So around here is the nidus. So what's the proximal embolization? Proximal embolization is the embolization of only the feeding artery while leaving the nidus of the region intact. But the proximal embolization results in the stimulation of a more aggressive neurovascular response. So many new collateral artery developed after the proximal embolization. So we must not do the proximal embolization. So we must eradicate the nidus. We must aggressive control of the nidus is essential to prevent recurrence. Usually with ethanol, sclerosant, glue, and onyx to eradicate the nidus. And the coil or ABPR has only the adjunctive role, additional role. So in a type 1 is arteriovenous fistula, so it's very easy to recognize the nidus and embolize. And in a type 2, the main target of the type 2 AVMs is the venous component of the nidus, because there are so many feeding arteries, so we can't embolize the whole feeding arteries. Of course, we embolize some of them. However, we must eradicate the nidus, so that we must embolize the venous component here. So the transvenous approach and direct puncture is preferred in this kind of AVMs. And sometimes we put the coils and we get the stagnation of the flow. Then we use alcohol or glue to eradicate the nidus. In the type 3 and type 3B, in the type 3A, only the transarterial approach is available for this type of type 3 AVM, because the fistula is too fine for the direct puncture. On the other hand, in the type 3B, we can treat by the transarterial approach and also direct puncture, because the fistula is larger compared to the type 3A, so we can puncture some of the fistula and inject alcohol. And this is a therapeutic outcome of the AVM according to this Samson classification. And type 2 is a better result because it's a little easier to treat. And then next I talk about embolic material and sclerosant. Usually we use alcohol, ethanol, and sometimes coil glue. And ethanol is a very essential sclerosant for the treatment of the AVMs. When we inject alcohol, patient feel pain. So usually we perform the procedure under general anesthesia. And also staged multi-session embolotherapy to reduce the risk is important to reduce the risk of too extensive embolization. Embolization using alcohol is not always safe, so we must separate the procedure. And the total dose of ethanol must be less than 0.5 milliliter per kilogram of the body in one session. And a single bolus injection of the ethanol must be less than 0.1 milliliter per kilogram. And if we use the large amount of alcohol, Swan-Ganz catheter insertion is essential to monitor the pulmonary artery pressure. And NBCA, of course, we use a NBCA mixed with Riparodol. And maybe you know very well about the NBCA, so I omit. So I will show you some case. The first one is the forearm AVMs, 39-year-old male, 30-year-old male, and he feel pain. It's the dynamic CT. You can see the abnormal dilated vessels around here, but CT can useful to grasp the whole feature, but it's not useful to recognize the nidus. So we performed angiography and selective angiography. For example, in this angiography, maybe around here is the type 2. So at first I puncture the venous component of the nidus. Then we performed angiography under compression of the brachial artery. So it's maybe I think that it's around them is all the venous component of the nidus. So at first I inject the coil from this needle, and we can get the stagnation of the flow. Then we inject the alcohol to eradicate the whole venous component. Finally, we inject the glue. It's a final result. Compared to the, you can see that around here, the nidus disappeared completely. It's a pre-embolization, post-embolization. And in this session, I treat around here, but also, of course, there are some nidus. So that in the next session, I embolize. The next case is the plantar AVMs. He's in his 20s. And several years history of progressive left foot pain and local swelling without previous trauma. Now he admitted to our hospital. And now the weight-bearing activities exacerbate the pain, so he can't walk correctly due to the foot pain. So this is a body rendering image of the CT, dynamic CT. You can see the huge AVM here. Then it's an angiography from the peripheral artery. You can see the AVM here. But also this imaging not so not enough to recognize the nidus. So every time I asked for myself, where is the nidus? And in Japan, we can use a micro balloon catheter. So I advance a micro catheter to the plantar artery. So this angiography clearly visualized it's a type 2 AVM. Multiple feeding artery shunting to the venous component. So the treatment option is direct puncture, but in this case we advance the micro balloon catheter more deeply and inject the sclerosant mixed with the air, like this. So in this case, I like to embolize the whole venous component and the whole feeding arteries. However, after the procedure, you can see the alteration occurred. Of course, the nidus is completely eradicated. However, the complication, we encounter complication. In the second session, you can see that one of the feeding arteries is completely embolized. However, the humerus quadral artery developed after that. So that this time, I punctured the drainage vein and advanced a microcatheter to the nidus. and put the coils and inject alcohol. And then puncture another point. And then I have punctured another point, and you can see that maybe this is a type 2, type 3B, so that I inject alcohol here. Then after the 2 sessions, almost ABM completely embolized. Now the ABM is getting smaller, and the patient pain dips, and the patient can walk, and now he's working. The next case is the Tonga ABM. And she came to a hospital due to the sudden bleeding. In the lunchtime, she was eating the lunch with her friend. At that time, she presented with sudden bleeding from the tongue. And she was hemodynamically unstable and transported to a hospital. And the dentist sutured a bleeding point like this. And after a few weeks, we performed angiography. And the ringal angiography was performed, and you can see the type 3A AVM. Fine arteries shunting to the fine veins, many veins. So but it's very difficult to treat because it's a tongue. So we don't want to use alcohol. So in this case, I inject I embolize using the microsphere, like this. And then now the outside healing, and ABM is getting smaller and smaller. However, maybe it's not a complete treatment. In the next case, the foot ABMs. He is suffering from the intractable ulcer on the foot. And this is a case from the Osaka University. You can feel there is an ulcer. So that Dr. Osaka punctured the AVMs and inject alcohol. After the first session, he treated here. Next, he treated here. Finally, outside healed. So we must select a treatment or select the embolic materials depend on the situation of the patient and depend on the vascular architecture. So it's a take-home message. Angiographic finding classification is very important for the treatment. And we must recognize the nidus. And we must select the approach to the nidus. Thank you for your attention.
Thank you very much for Professor Masanori Ino with a very nice presentation concerning about the event. And with a different classification also on the analysis of nidus, and also for the approach, for arterial approach or venous approach, and also for different material using uncone or sclerosin, and also for onyx or NBCA or coin. And do you have any question from audience concerning about this topic, please? You don't have any question, please. We move next speaker, Dr. Terence Teo from the Pathway Health Elizabeth Hospital from Singapore, with the topic of postpartum bleeding.
I'll be talking a little bit on postpartum hemorrhage. So I would like to acknowledge my colleagues from back in Singapore who have helped to provide me some of the material for the discussion today. So this is the outline of what is PPH and the causes, some management options, and what's the usual situation, whether it's in an elective setting or it's an emergent setting. Now we know that the PPH or obstetric hemorrhage occurs in about 10% of all live births and It's a cause of 24% of all maternal births. 2/3 of these are severe due to obstetric hemorrhage. The amount is such that it's causing hemodynamically instability, and arbitrarily is taken as 500 ml for vaginal delivery and more than a liter for a C-section. Primary and secondary is based on when it occurs, whether is it within 24 hours or beyond 24 hours. An easy way to remember PPH is, I think it's something that we learned back in medical school a long time ago. Tone, tissue, trauma, and thrombin. So I won't go much into that. Some of the management options, I think this is what most obstetricians will do when it occurs in an emergent setting. You massage the uterus and up the dose of the oxytocin. And hysterectomy will be one of the options in the event of torrential bleeding, but that's not something that I will discuss here. I'm not sure why it disappeared. Okay. And the other one will be conservative treatment, which is embolization. So some medical therapy will be to assess the uterus for tone and so forth. Again, this is something that the obstetrician will do, nothing to do with us. I have seen a situation where the obstetrician actually put a fist through the vaginal cavity to try to compress the uterus before when I was a medical student. I can tell you it's not very elegant. I've only seen it once and traumatized me for life. You can put an intrauterine balloon tamponade, and that's successful in 85% of the time. And embolization should always be considered if the tamponade fails or within 30 minutes of oxytocin therapy, and that doesn't stop the bleeding. So pelvic artery embolization was first reported a long time ago and is being increasingly accepted as a first-line approach when conservative management have otherwise failed. And in fact, in a very recent, maybe not so recent, 2007 good practice guideline from the UK Royal College, is that they in fact urge all obstetric units to have IR support so as to provide embolization support in the event of PPH. Now, what are the advantage when it comes to embolization? First is that the uterus is preserved so that future pregnancy is possible, especially for patients who have not completed their family, and that fails, patient can still go ahead and do hysterectomy. But if arterial ligation fails, it's impossible to do embolization. So when is the IR asked to help? We are usually asked to help when it's elective or it's an emergent setting. An elective setting is when problems are anticipated. Like for example, from the patient's history, previous DNC, myomectomy, C-section, and antenatal ultrasound, which is probably very important because it tells us where is the location of the placenta. And very rarely performed is the MRI. Although it does give us a very good appreciation of the underlying uterine anatomy. This is just a simple slide to understand how is placenta previa anticipated in the prenatal setting. We expect the placenta to be at the top of the uterus near the fundus, but that's not always so. You have a low implantation placenta or partial implantation and a total implantation where the uterus really prevents the baby's head from coming out. Next, we have different types of placenta, whether it is accreta, increta, or percreta. Again, it really depends on how invasive the placenta is into the myometrium of the uterus and whether it is easily separable. And that's actually what you want. You want a placenta which is easily separated from the uterine wall. So this is what you will see when you open up the patient. You see where the green circle is, that's where the implanted placenta is. The patient, because this is an elective procedure with C-section, is controlled. The obstetrician did not attempt to harvest, or to rather not harvest, but to remove the placenta, but to leave it there because it's an increta or it's a percreta. Now, because if it's an elective setting, what are the simple things that we can do? I think it is important that as we become a more and more clinical subspecialty, we really need to speak to the patient and the significant other. I write the word significant other because in today's day and age, not every father is necessarily going to be the husband or if the patients are married. I think that's important also because it helps us to develop a relationship with the patient as well as during the consent taking. A lot of times it's important for the radiologist to help in the coordinating care, because from the transfer of the patient from the delivery suite to the angio suite may take a little bit of help from everybody, and to get the bloods ready as well as the woman ICU to anticipate the delivery, the transfer of patient post-procedure. If it's an elective setting, we usually will want to place a balloon in the internal iliacs, place in a urinary catheter first, shave the groin as usual, bilateral 6 French sheath. The reason why you do it under 6 French sheath is because the Fogarty balloon is a 5.5 French Fogarty balloon, which is a occlusive balloon. Reduce the radiation dose to the patient, do it under ultrasound guidance, you know exactly where your needle tip is going, it's a single wall puncture. And do fluoroscopic grab only with contrast injection if necessary. Don't do any DSA because you know the DSA radiation dose is going to be higher. Use a Cobra C2, and we can test inflate one side at a time with LAO or LAO orientation, because what we want to see is to square the balloon is to make sure that it's adequate occlusion, and then we had to make sure that it's completely deflated as well before we send the patient across to the delivery suite for the delivery. Okay, this is a merged picture, and that will explain why there's one catheter missing on the left side. It is not magic. You can see the squaring of the balloon on both sides, and that's very clearly appreciated. Next, you need to make sure that everything is secured down. Some people will put in a Teflon wire to make sure that nothing moves. Some do that, some don't. It doesn't really matter. I don't. My colleague do leave them the Teflon wires in just to make sure it doesn't move around. Secure everything down in place. Keep the hub at the ankle for easy access, because as you can understand, when they're doing a C-section, everything is very bloody. You don't want to be in there. You want to be giving and inflating the balloon at the level of ankle, far, far away from where the main action is. Because at the end of the day, this is what you want to prevent, 12 packets of blood from having to infuse. So what to do next? In a scenario one where there is a placenta accreta, you want to quickly inflate the balloons after the fetus is delivered and the umbilicus is ligated. They try to do a surgical resection, a surgical removal of the placenta if possible, because this is not completely going to the myometrium. You can subsequently then deflate the balloon and watch for rebleeding, and this is probably one of the most torturous part of the procedure, because you literally stand there for 30 minutes and wait before the obstetrician closes up the uterus. If it rebleeds, you can always reinflate the balloon and then transfer the patient to radiology for embolization. If that fails, then the patient undergoes a hysterectomy. And if there's no bleeding, you can leave the balloon deflated and observe for up to 24 hours. Some people do that and some people don't. What happens if it's increta or percreta, which means that the placenta has invaded into the myometrium a little bit more deeply? The initial part is literally the same, except the obstetrician will not deliver the placenta and leave it in there. They close the abdominal incision, transfer the patient down to radiology to have either super selective uterine embolization or non-targeted IIA embolization, depending on your preference. So at the end of the day, same thing, this is what you want to prevent: too much blood loss. You want to control the blood loss so that the patient do not need to have too much blood products. So the procedure is actually very similar as you expect to UFE, and the only difference is that you find that the vessels looks really, really different from what you normally see in a UFE procedure. Something post-embolization, this is what you want to see, really minimal blood flow. And then this one is a little bit more complicated on the right side, because it seems that the feeding artery is a little bit more deeper. You can go in there with your bigger catheter, 4 French catheter is fine, and then give your gel foam, and then you are basically done. Also, all you're trying to do is to reduce the blood flow so that you can give the oxytocin some time to work, you give the uterus some time to work, and you basically buy yourself some time. Post-embolization, you can keep the right femoral sheath for up to 24 hours, and that allows you easier access if rebleed. There is no need to keep the left groin sheath, just keep the right side is enough. Close monitoring in the woman ICU, and then of course, because you're putting a sheath in, make sure you run in some normal saline, about 1 ml per minute, and to monitor the distal pulses. and of course the regular pain management. And if patient is stable, we can always remove the sheath 24 hours later. Okay, so there is some papers out there, and this is a paper that was written in Singapore about 10 years ago, and there was definitely some statistically significant reduction in the blood loss and the amount of blood that is required for the transfusion. And if the patient do go for surgery, there is also a significant reduction in the operative time. And this is not just seen in our paper, but it's also seen elsewhere in the rest of the world, as you can see. But the main problem, as you can see, is that the number of cases is actually low. It doesn't occur very often, and I think things like hysterectomy and so forth, these are things that some patients may choose if they have completed their family. Because remember, one of the risk factors that they have from before is they have a previous C-section, which means that the uterus is really scarred. So this may be the third or even fourth pregnancy, and patients basically have enough kids and they do not want to have a family anymore. Nonetheless, whether you want to place the balloon in the IIA can be controversial, with some investigators saying there's some some benefit, and some others saying that it doesn't make much of a difference. So that's the elective part. That's when everything is controlled, everybody knows what's going on. But as you know, most of the time that doesn't happen. When they usually call you is when the obstetrician or even the general surgeons or the urologist has mucked around a little bit for a while, and then when they call you, patient is really nearly pale. In such a setting, same thing, transfemoral approach, you cannulate both the internal iliac artery, and then if you can, selectively cannulate the uterine artery. At this time, a lot of times the patient is really hemodynamically unstable, which means that they are vasodilated. And you also have to remember that we are dealing with women who are otherwise well. So you're not dealing with tortuous vessel, you're not dealing with dilated aneurysmal vessel, you're not dealing with vessel which has undergone a lot of atherosclerotic disease. These are good, pristine vessels which are clean, and the vessels spasm very easily. You can give a gel foam slurry until they are stasis, and it is not necessary to see an extravasation point before going ahead to do embolization. Because as we are all familiar, gel foam slurry only stays there for a short while and the artery will recanalize. If a specific bleeding point is found, good, we go there and we do the regular thing called embolization, particles and so forth. Sometimes you may see some pseudoaneurysm or some fistula. If you can, go super selective. If not, it doesn't really matter. Just give gel foam, you'll be fine. The reason why gel foam is good, because you preserve uterine perfusion and future fertility. You must remember that these patients are not atherosclerotic disease. They do not have abnormal blood vessels. They do not have uterine fibroids for you to embolize. So it's basically a temporizing measure pending medical therapy. Usually you do not use particles because of the high risk of ischemia. And following that, we do a flush aortogram to see if there's any significant contribution to the uterine fundus from the ovarian arteries, and sometimes even cannulating the inferior epigastric artery if need to. And elsewhere, they show that the success rate is actually very high, and if there's any risk of recurrence, it's usually due to collateralization, and if need be, repeat embolization is always a possibility. Unfortunately, sometimes the unrecognized abnormal placentation may be a cause of failed embolization. Overall complications rates are relatively low, and usually most are minor and related to the arterial puncture or contrast reaction. Post-embolization syndrome is common, and this is expected. It is the same as elsewhere when we do TACE and elsewhere. There's nothing really, they are usually very self-limiting. Ischemic complication is usually self-limiting, not self-limiting, ischemic complications are usually rare, and you can prevent that from happening if you don't use particles and so forth. Other than that, some of the claudication that will resolve by itself, the rest may not be so straightforward. Neurological communication with the internal iliacs and the artery supplying the spinal cord and vessel and the nerves are also some other possible complication. So the conclusion is that it is important to let your O&G service know that what you are able to provide is available, and it's important for us to be involved very early in the planning and the care of these patients. And in fact, because you can do this quite safely, it should be the first choice before hysterectomy. because hysterectomy, as you know, has its own complication like ureteric injury as well as bladder injury. And I think in our own setting, we have seen that happen often enough. Embolization is safe and effective because we are using something that is temporizing. And again, remember, these patients do not have arteriosclerotic disease, nor do they have uterine fibroids. There's a low complication rate, and most importantly, it preserves fertility, especially if this is the first or second child. Thank you very much.
Thank you very much, Dr. Terence. Any question? So if we don't have any question, please move to Professor Inoue, please. Professor Inoue will have a topic about aneurysm management.
Hello again. My third presentation is about the visceral artery aneurysm management. Visceral artery aneurysms are relatively rare clinical entities. Although the incidence of this diagnosis is increasing due to the increased use of the CT. And of course, the rupture is the most critical complication with a high morbidity and mortality. For this reason, elective repair is preferable in the appropriate chosen patient. Not all patient, but the appropriately chosen patient. And incidence not so high, and most are asymptomatic. And the splenic artery aneurysm, hepatic artery, renal arteries are very common. And treatment indication is different depending on the location and the size. So at first, I talk about the pancreatic duodenal artery aneurysms. This aneurysm, the incidence is relatively high in patients with median arcade ligament syndrome. And the natural history of this aneurysm is unpredictable. That means this kind of aneurysm rupture irrespective of the size. Very small size aneurysm, there is a risk of rupture. So we must treat this aneurysm even smaller size. So it's a case of the ruptured small pancreatic duodenal artery aneurysm. You can see the huge hematoma in the retroperitoneal space. Also, you can see the tiny aneurysm here in the pancreatic arcade. Now, this is an angiography from the celiac artery. You can see the small aneurysm in the arcade of the pancreatic arcade. The size is very small. However, in this location, aneurysm rupture, and we embolize. The next, splenic artery aneurysm. Usually the indication is more than 2 centimeters in size, and a female gender within the childbearing age. Because during the pregnant, the aneurysm is getting bigger and the risk of rupture. And also the liver transplant recipient. And the renal artery aneurysm. The size is more than 2 centimeters. And also the female gender with childbearing age. And aneurysm with symptom. But more recently, very famous paper was published from the Journal of Vascular Surgery. And in this paper, this large contemporary multidisciplinary study demonstrated that asymptomatic renal artery aneurysms rarely rupture. Even the size is more than 2 centimeters. So then concluded that current indication is too aggressive. But also there are some case reports about the rupture of the renal artery aneurysm. In this paper, Patient is 66-year-old female, and no history of trauma. And she presented with a sudden onset of lower back pain. And the renal artery aneurysm rupture. The size is about 17 millimeter. So I think that there is a room for discussion about the treatment indication of the renal artery aneurysm. And also if the size is getting bigger and bigger, it's more difficult to embolize. So I think that around the 2 centimeter is a good indication. So next, I'll move on to the endosaccular packing using detachable coil. Now, when we treat the aneurysm, for example, the renal artery aneurysm, we must preserve the parent artery. So the packing of the aneurysm is a good option. Because, however, same as the cranial aneurysm, there's a risk of the recanalization of the coil compaction, especially for the large and wide neck aneurysm. And as I previously mentioned, our indication is about 2 centimeter, so it's classified as a large aneurysm. So that we need several adjunctive technique to embolize the aneurysm very densely, tightly. Now, this is a basic concept for sac packing. There are 3 steps: framing, filling, and finishing. And usually we use a 3D shape detachable coils. At first, we insert the coil inside the aneurysm like this and make the good frame. Then we insert the smaller coil to make frame more rigid. And after that, we insert many coils inside the frame. Finally, we embolize the location near the neck. It's a filling, a finishing. So now in Japan, we can use many neuro coils for the peripheral intervention. So there are many detachable coils. This kind of coil is very soft and without fiber on the bare coil. And we can easily remove the foil if the unoptimal location. It's a movie of the 3D coil using the aneurysm model. I'm sorry. And the 3D shaped coil is made for the embolization of the aneurysm. So it's move and make the good frame inside the aneurysm. It's totally different from the 2D shaped coil. It's a framing. And I talk about the essential knowledge you must know. What is a wide neck aneurysm? The definition is the dome to neck ratio is less than 2. It's a definition of the wide neck aneurysm. And also you must know the packing density, volume embolization ratio. Volume embolization ratio is calculated by this formula. And it's one of the criteria when we finish the embolization. And according to the paper, we must use many coils, and VR must be over the 24% to prevent the recanalization or the coil compaction. And this is adjunctive techniques of the sac packing. When we treat the wide neck aneurysm, coil is easily protruded to the parent artery, so we use a balloon to protect the coil protrusion. It's a balloon neck plastic technique. And also sometimes we use a stent to prevent the protrusion of the coil. And also usually we use a 2 micro catheter. The balloon neck pulsing technique, we use a flexed balloon and advance the balloon to across the neck, aneurysm neck like this. And temporarily, we inflate the balloon to protect the coil protrusion. And also during a procedure, optimal working angle is a barrel view. It's a frontal view, and the barrel view is a view from the tangential to the balloon. So in this working angle, we can differentiate the parent artery and the aneurysm lumen very clearly. So in this figure, in the frontal view, coil mass looks like protruded to the parent artery. However, in this barrel view, coil mass don't protrude to the parent artery. So this is the best working angle. It's a real case. In the barrel view, you can see that this is a balloon. So the coil mass doesn't protrude to the parent artery. However, in the frontal view, coil mass looks like protruded to the parent artery. So that this barrel view is essential for the coil embolization. Now, so the guiding sheath is very important to treat the visceral arterial aneurysm. In Japan, we can use various types of the guiding catheter. Usually, we use the Shimaduk type or the Simond type. And usually, we put the 2 guiding sheaths to the renal artery. And I advance the micro balloon catheter from 1 guiding sheath. And 2 micro catheter were inserted from the other guiding sheath. So we need 2 guiding sheaths. So I'll show you a case. So in this case, you can see that the neck is not so wide. So this kind of aneurysm is very easy to treat. I insert the 2 guiding catheter here, and you can see the aneurysm here. The neck is not so wide. And you can see the balloon here. I put the balloon at the neck. And also you can see the 2 micro catheter inside the aneurysm. Then we put many coils. And the volume embolization ratio is 35%. It's enough. It's a final result. Aneurysm is completely embolized using the many coils. So next I'd like to talk about the double microcatheter technique. Of course, the purpose is place more coils inside the aneurysm. But the more important point is if we use a double microcatheter technique, we can't prevent the coil protrusion to the parent artery, because if we use only 1 microcatheter, at first we insert 1 coil inside the aneurysm and detach. Then we insert the second coil. However, sometimes the second coil pushes out the first coil to the parent artery, but at that time we can do nothing. But if we use 2 microcatheter, we can prevent such kind of coil protrusion, because at first we insert the first coil to the aneurysm. Then the first coil is not detached. Then we insert the second coil through the other microcatheter and make the rigid frame. After that, we detach the first coil. If the first coil, second coil push out the first coil to the parent artery, of course we can remove the first coil. So I'll show you the movie. This is a case of the right renal artery aneurysm. Here. Now this is a very wide neck aneurysm. So the coil is easy to protrude to the parent artery. So in in this case, I inserted the 2 guiding seeds and 1 microballoon and 2 microcatheter into the aneurysm. And this is a renal angiography. Yeah. Very wide neck. So I put the balloon across the neck. It's a balloon neck plastic technique. And you can see the 2 microcatheter inside the aneurysm. At first, I insert the first coil into the aneurysm. However, the frame is not rigid, and also coil is moving. Before I detach the first coil, I insert the second coil through the other microcatheter. And 2 microcoil make the very rigid frame. And after we certain that the first coil does not protrude to the parent artery, we detach the first coil, and then we insert the third coil. So it's very safe. And we insert the more coil. It's a final result. Aneurysm is completely embolized with the coil. Packing density is at 26%. It's enough. So the next I talk about the advanced technique. Sometimes we must use the 2 microballoon catheter to protect the parent artery. In this case, the renal artery aneurysm is frequently located in the trifurcation of the renal artery, like this trifurcation. Also, the neck, there is no neck. So this kind of aneurysm is very difficult to treat with preservation of the parent artery. Very huge aneurysm, you can see. But it's a completion angiography in the first session. In the first session, I treat using the 1 microballoon and 2 microcatheter. However, you can see that around here, coil mass is not so dense. So it's a follow-up angiography. You can see the coil compaction. Here is the space. So I performed the second session. So in this session, I put the 2 microballoon catheter in the dorsal and the ventral branch of the renal artery like this. And I insert the 1 microcatheter into the aneurysm and embolize like this. Finally, the aneurysm completely embolized. Packing density is 31%. In the last case, stent assist technique. This is a female patient in her 50s, and the size of the aneurysm is 32 millimeters, so big. Also, the aneurysm is located at the trifurcation. So I think that in this aneurysm, we can treat without a stent assist technique. So I put 1 stent here and embolize like this. However, 1 year after the procedure, you can see the coil compaction. So I performed the second intervention, and finally, the aneurysm is completely embolized. So when the aneurysm is getting larger and larger, sometimes coil compaction occurs. So we need a second session. So it's a take-home message. When we treat the aneurysm by the sac packing, 3D shape, the coil is essential. Now also the visceral arterial aneurysms are often very large and with a wide neck. So the adjunctive technique is essential. Thank you for your attention.
Thank you for your very interesting talk. Any questions from the floor? Yes, please.
Thank you very much for your very good presentation. Have one question. Because you show many techniques for coiling the aneurysm. But if the aneurysm at the tongue or the main artery, like main renal artery, do you have any experience using cover stent? Thank you.
I have in one case I use a covered stent, but as for the renal artery, usually renal artery aneurysm is located at the hilum or the trifurcation, so we can't use the stent graft. However, if the aneurysm is located in the main trunk of the renal artery, we can use. But in the splenic artery aneurysm or the hepatic artery aneurysm, sometimes we use the stent graft because now we can use the bioban stent graft. Bioban stent graft is a very sophisticated device, so it's one of the options, I think.
Okay, thank you.
I have one question. Is it easy to have 2, 3 catheters just sitting at the origin of the renal artery when you're doing that? Because you have the balloon across, you have 2 balloons across, and you have another one that's the microcatheter going to give the coils, to deploy the coils. Is it stable at the renal artery origin when you are having 2 to 3 catheters right at the origin? Because you have the bigger, you got the 4 French catheters, now you have 3 4 French catheters sitting at the origin.
Your question about we insert more catheter, no?
So you have the balloon to protect the branches, right? So now you have one balloon that is going through one catheter, and then
balloon can't complete. Balloon catheter can't protect the parent artery completely because the neck is so wide. So of course sometimes the balloon is effective, but not completely protect the coil protrusion. And usually 2 guiding catheter is no problem. Yeah. I don't know, but yeah. But usually we don't need 3 guiding seats. 2 guiding seats is enough because we can insert the balloon catheter and the two micro catheter.
And where do you get you puncture both groins, or you puncture the brachial artery, or
usually
one big sheath?
Usually both groin. Yeah.
I have a question. What is indication in case of the renal aneurysm? What is indication for the embolization?
Renal artery aneurysm?
Yeah, renal aneurysm.
Usually, I mentioned, I said in the slide, usually the size is around 2 centimeters. And especially the young girl who in the childbearing age, is the indication.
When you see...
And according to the paper, calcification doesn't prevent the rupture. So if there's a calcification, we treat.
But however, it can you can guess that it can stable. It can be stable in the future. For example, aneurysm about 15 millimeters, for example, with calcification, and you keep the aneurysm to follow up, or you do
that's right.
embolization.
According to the paper, renal artery aneurysm rarely rupture. So the indication is very controversial now. But if the aneurysm is getting bigger, it's very difficult to treat. And also there's a case report that renal artery aneurysm less than 2 centimeter rupture. So I talk about the patient all things. And but the patient usually don't want to undergo the surgery, but patient want to undergo the endovascular treatment. So also in Japan, the endovascular treatment is covered by the health insurance system. So the my indication for the renal arterial aneurysm is about the 2 centimeter.
Do you have some special protocol for the anticoagulant after the intervention?
Image follow-up?
Yeah, follow-up and the medicament you give for the patient.
And of course, we put many coils, so the CT is not effective. So MRI angiography is we use the MRI angiography for the follow-up.
For anticoagulation, for example, heparin.
Usually, before the procedure, I start the DAPT, double antiplatelet therapy, and after that, after 6 months, we continue to the DAPT, and then we use the only one drug. It's the same as the medial brain aneurysm or the CAS. Yeah.
Thank you. Shall we move on to the next speaker? I'd like to invite Dr. Nguyen to come and speak to us about GI bleeding.
Hello, everyone. My talk today is about management of gastrointestinal hemorrhage. The goal of intervention for gastrointestinal bleeding is effectively, safety and promptly. Effectively means the interventional radiologist has to be experienced, and we have enough supplies for example, for the catheter, the guide wire, and all the embolic materials are available. The safety means we have the patient has to be well prepared during and after the procedure, and promptly doesn't mean we have to do the procedure as soon as possible, because we know that GI bleeding is intermittent. Sometimes it can stop and it start again, so we have to indicate to do angiography when the patient has the active bleeding. GI bleeding can be divided into upper GI bleeding or lower. Depends on the symptoms and the different techniques to stop bleeding. Normally, the upper GI bleeding is more common than the lower GI bleeding, and it often massive and life-threatening. Well, because of the cause of the upper GI bleeding and lower GI bleeding is different. With the upper GI bleeding, normally we have a lot. The common cause is ulcer or erosion of gastric of the stomach or duodenum. Why the lower GI bleeding cause is often come from the diverticular disease or anal fissure. The different anatomy between the GI gastrointestinal tract, upper and lower, upper GI tract, we have a lot of collateral circulation, so it can make the embolization more challenging. We have to occlude the two parts of okay. We have to occlude the the door, the back door, and the front door when we considered about the occlusion of upper GI bleeding. But in lower GI bleeding, we have some difference that we have marginal. Pointer, please, sir. No. Okay. Because we have a marginal artery and a lot of the perforating artery. So the there is the marginal arteries that we should preserve it as soon as and the perforating arteries, we can occlude it to stop bleeding without any complication of ischemia. Okay, the indication for angiography of the patient is when the patient has a massive bleeding and with refractory or medical treatment or endoscopy, the patient has a recurrent bleeding after surgery. Yeah. The first choice when manage the GI bleeding is the medicament or endoscopy, but sometimes with very massive bleeding, we have to do very fast, directly angiosus without any delay. The catheters we often use for GI bleeding is the ER0, that is very common in Vietnam, because this catheter is very easy to access in the celiac trunk or the SMA. Sometimes we use the RS because it's very strong, very hard to support to access in some difficult angulation of the celiac trunk, for example. The material embolization is very important, and we have to know about the advantage and disadvantage of all of the material embolization. The permanent material embolization is, for example, the coil particle or glue. The coil with the fiber can conduct the thrombus, and it can occlude the vessel. But the permanent is quite relative, because, for example, when the patient has a coagulopathy, the coil alone cannot conduct the thrombus. So we have to consider about that. Before intervention, we have to perform we have to consider that all the GI bleeding is intermittent. So just indicates the patient when they have active bleeding. We also have to correct the anticoagulopathy for the patient, and we should have a very good relation with the clinical doctor, especially the surgeon, the digestive surgeon, or gastrointestinal, and we have to very well explain for the patient, relative or family, because some bad thing can be happen when after the procedure. After procedure intervention, we just follow the very valuable factor to prognose if the bleeding is stopped or not is hemoglobin. hemoglobin can decrease a little bit just after the embolization, even when the procedure is successful, because during the procedure it continues bleeding, and when we transfuse blood transfusion and follow up the hemoglobin is very good to see if the rebleed or not. If rebleeding, it can be bleed at the point we embolize, or it can bleed other position. The pattern on angiography we can see is the direct side or indirect side. The only one direct side of bleeding is the extravasation. And sometimes we can see the indirect side, for example, the aneurysm, hypervascularity, or irregularity, or even normal. A lot of patients with active bleeding, we see the normal pattern on angiogram. CTA is very important before intervention. When the patient permit, we can do CT scanner for the good planning before the procedure. For example, this patient has active bleeding. On CT scanner, we see diverticule with a hypervascularity in the wall. On angiography, we didn't see the extravasation, but we see the small branch come to the diverticule, and we just occlude that by coil, and it stop bleeding. The other patient has after a laparoscopic for the gallbladder stone, after one week, the patient has bleeding, and CT scanner show the quite big aneurysm, pseudo aneurysm at the hepatic hillock, and on angiography we see very well, and it can occlude by coil. The other patient, man for 74 years old with a head of pancreatic tumor, unresectable. In the hospital, we put the stent to drainage the bile, but we also put the drainage, and after 1 week we withdraw the drainage. And just after withdrawing the drainage, the patient has a symptom of very massive bleeding and severe condition. So we decided to do angiography directly without doing the CT scanner. And on the angiography, with the total angiography, we didn't see the lesion, but selectively we see the small dissection of the right hepatic artery at the position of the puncture pathway, and we occlude it with glue, and the patient is recovered quite well after. Other patient has the medical history of duodenal ulcer. Suddenly has hematemesis, vomiting, blood vomiting, and on CTA we see the extravasation at the position of duodenal, and because of the massive bleeding and active bleeding, we do angiography and see very small extravasation at this point, and more selective, we see the very small branch come from the gastroduodenal, come to the lesion, and a small branch here come to gallbladder, and because we cannot advance the microcatheter into the lesion, so we occlude the the branch, the distal and the proximal branch by coil. And we also do the angiography for the SMA to conclude to confirm that there's no collateral circulation into the lesion. Other patient with after small bowel restriction due to the ileal obstruction because of the ligament, she has very severe fresh blood in the stool, and inferior mesenteric arteries is showed there is the it's a frustration at this point, and very selective with the microcatheter, the neuromicrocatheter. We can see the two marker here, and at this point we can occlude it because this is a perforating branch. We can occlude it by coil, very small coil, and it occlude. Other patient has the very fresh blood in the cecum on endoscopy, but there's no lesion in the mucosal layer of the duodenum. And on CT scanner, there is a little bit thickening of the wall of the cecum, and on MIP reformat, we see some vessel. So we decided to do angiography for the patient, and just the hypervascularity of the cecum. More selective, we see the some drainage vein. It's quite early phase, so there's some possibilities for diagnosing the patient. The most likely is the angiodysplasia, and maybe it can be the tumor, hypervascular tumor, or AVM. So anyway, we have to occlude this lesion to stop bleeding. So the material, embolic material we use is PVA. We just inject just a little bit, and then take the angiography, and then inject when we didn't see the drainage vein, and we can stop. We can see also the sterile perfusion of the cecum, and the patient recovers. There's no ischemia. Other patient has also massive severe bleeding lower GI tract. On angiography, we see the extravasation very of the small branch go to the hepatic angle of the colon, and the microcatheter can advance until this to the lesion, and with this position we cannot use the particle, or we cannot use the glue, because it's very dangerous at this position. We put a coil, and it stops bleeding. And you see the marginal artery is occlude. Normally, when we can occlude the marginal artery without any problem, but this patient today after embolization, she has symptom of peritonitis and elevation of white blood cell. The surgeon operates her and show the ischemic. So for the colon, we can occlude the perforate arteries very with the confidence. There's no any ischemia, but sometimes we have to occlude the marginal artery, and that is quite dangerous. Okay, so in we recommend that with the GI bleeding angiography, we should do very selective angiography to reveal the lesion. is as selective as possible. And we can use the first choice, we can use the coil when we selective, but only coil is sometimes not enough. And in upper GI bleeding, we should do the sandwich technique, and if we cannot advance the microcatheter to selective, we have to do scatter embolization. It is that we don't recommend, but sometimes we have to use to stop bleeding, and sometimes we have to occlude blunt embolization. With the upper GI bleeding, we have to perform when the patient as soon as possible, because the literature show that the early we do the procedure, the less complication of the patient got. And we have to correct the anticoagulation, and because the patient often have associated with coagulopathy, so we in that case we don't use only the coil. Coil is not enough. The empiric embolization is that sometimes we don't see the extravasation or the lesion on the angiography, but on endoscopy they show very well the position of the bleeding. For example, the fundus of the stomach. So we just occlude the left gastric artery. And with upper GI bleeding is very rare. We see the complication of ischemia. With the lower GI bleeding, we have to do embolization more selective as possible, and we see should use the embolization, the perforate artery. And sometimes we have to do the marginal arteries if necessary, and because of the less collateral supply, but when we do very well technique, we are not faced with the complication of ischemia. Thank you.
Thank you very much for the very nice presentation. Any question from the hall? Well, if there is no question, I would like to invite Association Professor Bùi Văn Giang. His topic for today is renal artery embolization. Please.
Good afternoon. And now I'm talking about renal artery embolization in some pathology. And we begin by some case study, and we are talking about the problem in case if there's indication for the renal embolization. For example, this is a patient who have a kidney stone, and for this stone, the surgeon already performed the PCNN and PCNL. And after the operation, after the procedure, the patient have massive bleeding. And on the angio, CT angio, we can see that there is aneurysm. Okay. And on the CT angio, we can see that there's aneurysm, and we can say that this is pseudo-aneurysm after the intervention here, and it's shown clearly on the angiography that there's aneurysm and there's extravasation come into the calyx. And for this patient, we introduce a microcatheter to attend to the next of the four aneurysm. And because it's a four aneurysm, so we can discuss about the material to embolize. It may be coil or it may be the glue. In this case, we decide to choose glue to occlude the four pseudoaneurysm. And by injecting the glue, we can see that it comes into the pseudoaneurysm. And the reason I think that it's quite perfect. We can see the parenchyma of the renin, and the pseudoaneurysm is totally excluded. Another case is old lady who have pain in the lumbar pain, and clinically we can find there's a mass here, and on the ultrasound we can see that there's a hypoechogenic mass in the upper pole of the kidney, and on the CT scanner we can see clearly that there's a fat tissue inside the tumor with hemorrhage, which can in favor of AML and with some aneurysm rupture. And for this patient, we can see that we can choose angiography like therapeutic, because now the surgeon don't want to operate this patient. And on the angiography, we can see that is a typical of angiographic lesion of the AML, of the angiomyolipoma. And in this tumor, we can see that is hypervascularized with some aneurysm inside. And for this patient, we also another time that we choose glue to occlude this tumor. And when the glue come into the tumor, we can see that there's a big vessel here with some aneurysm. And the result, I think that we can happy with this result. There's a small cortical defect here, but on the total, the tumor is excluded with a large number of the parenchyma is reserved. Another case, which is very difficult for the surgeon, after the stone removal, the patient have quite massive bleeding, and during the 7 days after the operation, they have to take 2 unit blood transfusion. But on the angiography, we perform the angiography, but we do not see anything like lesion here. So maybe it's quite now it's very difficult for the surgeon and for us also. For us, we refuse to perform the occlusion, to perform some kind of embolization here. But for the surgeon, they say that they ask us that you must do something to stop bleeding. And in that case, after the discussion with the surgeon, we performed one kind of embolization, but by the transient embolic agent, that's mean by the gen form. And the quality of the image is not good enough, but we can see that the artery is totally occluded, but by the temporary embolic agent. Happily, this patient, clinically, the scene is go better. The bleeding is stopped. And we perform the Doppler ultrasound to check if the renal artery is recanalized. And if the tension of the patient is controllable. And some days after the procedure, everything goes normal. And the bleeding is stopped, and the arterial tension became normal. And we know that embolization for the renal artery have a young history. It's since 70 that we performed some first case, but after that the growing experience expanded the indication. And now the indication is quite large. The most popular indication for the embolization of the renal artery is symptomatic hematuria. And in some developed countries, when the palliative care for the cancer patient is very important, they perform a lot of palliative care, embolization or chemotherapy selective in case of the metastasis or the mass tumor in the renal of the kidney. And even in case there's indication for the operation, there's also the indication for the angiography and eventually the embolization before the operation. And in case of the benign tumor like angiomyolipoma, embolization is the first choice. But the number of these patients is not much in the European country. And the other indication like vascular malformation, there's also indication for the endovascular treatment. And in some end stage of the renal disease, there's also the indication of the renal embolization. Instead of perform the surgeon, they perform the embolization to exclude the renal from the body. And in some complication after the renal transplantation or the intervention, the occlusion of the renal artery is a good choice to protect the renal. But in Vietnam, I don't have the statistic number, but however, I have an impression that the most frequent indication that we met in the clinical practice is embolization for the angiomyolipoma. And in most of the cases, the patient come to the hospital due to the rupture of the aneurysm with a huge hematome, the retroperitoneal. And in some case, we have to treat vascular malformation. And now with some intervention, renal intervention, the complication increase. So that we receive very often the case, the patient come to the radiology department after the intervention, percutaneous or surgeon. And in that case, there's also the indication to embolize the renal artery to stop the bleeding. And in some big hospital like Vietnam Hospital, as you see, there's a lot of trauma, and including the renal trauma. And the embolization is also a conservative method applied more and more in that hospital. And I think that in the near future, we will perform some kind of treatment like palliative care for the metastasis or for the renal tumor to prepare for the patient. And last indication, which is very frequent in some developed country, but not very frequent in Vietnam, that's the end stage of the renal disease. In case after the transplantation, and the tension of the patient is not controllable, that's indication to exclude the renin by the embolization. And maybe in the future, when we perform a lot of renal transplantation, and in some special case, when the hypertension is uncontrollable, there's also the indication to occlude the renal artery instead of perform the operation to remove the renin. And this is another case. You see that the patient come with huge hematoma, retroperitoneal hematoma, and on the angiography, we can see that it's the same pathology like angiomyolipoma with some aneurysm. And for this patient, we have to use the coil to occlude the vessel, but it's not good enough. So after the coiling here, we perform also the embolization with the glue, and only with the glue that we can terminate the procedure. And at the beginning, with the coil, we cannot finish the embolization. And as you can see, that's because the tumor is huge, so that the pedicule can take a large part of the renin, and the embolization can exclude the tumor, but it's also to take a large number of the parenchyma of the kidney. And this is another case. I think that the quality of the image on the screen is not good enough to show you that there's a fistula, arteriovenous fistula here, which is indirect scene of vascular arteriovenous fistula of the vascular malformation. And in this case, we have also the indication to occlude the malformation. But because we cannot control the fistula, so we have to choose the coil to occlude the pedicule of the malformation. And happily, even with the coil in the pedicule of the malformation, in the future, we hope that there's no collateral to come in the malformation again. So even that's a malformation with the arteriovenous malformation fistula, but only with the coil we can occlude definitively the malformation. And for this procedure, we can see some complication, but most of them is very not very severe, like the fever, nose, vomiting, etc., or a little bit pain in the lumbar. Concerning the embolic agent, as we all know that there's two kinds. The not very frequently used is a temporary agent like a Zenform. However, if we don't have a Zenform in hand, in some case we have a difficulty to treat the embolization with a special indication, like the case I show you. When we only need the temporary embolization, and after that it take off and lets the vessel recanalize. And in case most of the case we use a permanent material like a particle coil, and there's a lot of kind of coil that we have to be familiar with to be able to choose the best coil for the intervention. And the liquid agent is one of the most frequent use in developed country, like in developing country like in Vietnam, because it's cheap and in most of the case it's very effective. And another material like a plug or balloon is also used in some special case. And no material is the best. Each material, each embolic agent has its own place, and the good indication is the best. There's no the best material for the old lesion. And for the conclusion, we must think about the difference between the indication made in in the developed country and in Vietnam. In Vietnam, we see that in most of the case we perform embolization is angiomyolipoma. Most of the cases, the patient come to the hospital for the rupture, and even in case we can see the angiomyolipoma, but without rupture, without symptomatic, we don't occlude the lesion. And vascular malformation is absolute indication for the embolization. And a complication following the renal intervention is more and more frequent, more and more met in the practice. And it's highly demanded by the surgeon to perform they ask the radiologist who performs the intervention to protect the kidney in case of the complication after the intervention. And in the future, because now that we are working in the oncology hospital, so we think that in the future we must think about some palliative care in case of the renal tumor, and especially in the oncology hospital, this pathology is very highly demanded. Thank you for your attention.
I'd like to invite any question from the floor for Professor Bui.
Thank you. I think yeah, wonderful lectures. Just a question about this use of the gel foam in empirical embolization of the kidney. In the case you illustrate where you don't find a bleeder, what is the clinical outcome of the kidneys on your subsequent follow-up? I know the renal artery we open, but the damage is not whether renal artery is occluded or not. It's damage to the renal cortical parenchyma and the filter mechanism. On your follow-up, did the patient, the kidney underwent the atrophic change and loss of kidney function, scarring or anything?
It's a short term. Yeah, we follow up the patient in the short term. That's mean 2 weeks after the intervention, when the patient stay in the hospital. And the reason is after the embolization, the bleeding is stopped. And that makes the patient happy and the surgeon very happy. And we afraid that maybe there's a hypertension after the embolization like that. So that's right after the intervention, we ask the opinion of the cardiologist who come in to give some medicament for the patient to control the hypertension. And that's why this patient don't have hypertension. But for several days after one week after the intervention, we just perform the color Doppler to verify if the renal artery is recanalized. And in that case, there's a signal of artery inside. But we don't have occasion to follow up long term.
The reason I ask you this is that because if you embolize a kidney like you whack the liver, I think the long-term outcome, which is something which nobody have any research on that, and if you are setting this a precedent for the next generation of the IR to come in to whack the renal artery indiscriminately, you have to be very careful. Renal arteries are end arteries, and the acute tuberous necrosis may not recover fully. Some of them will recover. I have cases where we have no choice but to take off significant segments of the renal artery, where we do see certain degree of recanalization and reperfusion to the kidney, but the function never come back to normal on that segment. We whack the kidney at that scale to wake up 2/3 of them. Invariably, in long term, they will going to come down with a lot of complication, and this is a practice we should not encourage our junior to do. This is my personal opinion. I don't know what the other the faculties think about it.
I think that is totally right. And even we have already discussed about that situation with the surgeon. That's maybe the function of the kidney never come back again. But the surgeon push to do the embolization, because if not, they have to perform the nephrectomy.
I think one thing is that when it comes to renal bleed, a lot of time for it to come out from the the urine as a hematuria, that means the bleeding must be from the calyces or the surface of the urothelium along the pelvic system. And there's one thing, number one, if you are looking, you think that AV fistula or aneurysm is the cause of the bleed, and then you have to go super selectively every single branch and do a thorough study with all kind of enhancement technique. Not infrequently you will fail to find that, and from my experience, a lot of them are actually self-limiting if you take all the necessary control. A lot of them are secondary infection, inflammation, when they cover them with antibiotic for about 4 weeks or 6 weeks. Second thing is that you have to really look actively, especially those patients with a risk profile of TCC, where you have to do this urine fish test to exclude transitional cell carcinoma, and not to forget early tumor, other angiographic abnormality along the entire urothelial system from both kidneys down to the bladder. And if RPG shows can localize to one side or a kidney, then that'll be easier. Otherwise, you have to really do thorough check and regular follow-up. Not infrequently, this bleeding. Actually, I have a bad experience where a lady had a recurrent bleed for 2 years after some stones in PCNR. And the urologist insists that the bleeding is from the kidneys, and I went in, do 2 sessions angio. I couldn't find anything which is abnormal. And one thing you have to be very careful when you deal with surgeons is they do not tell you the true story. I keep asking, are you sure there's nothing else causing the bleed from the bladder after the kidney? No, never. You can be the rest assured anything outside kidney is normal. Sure normal. 2 sessions of angio failed to detect the source of bleed, and he went in and have done 20-hour sessions of clot clearance from the bladder and 20-hour sessions of retrograde ureteroscopy, which essentially blood clot, no tumor. Sure enough, no tumor. The final round is there was actually a big hole he created between the left ureter and the left common artery. There was a huge arterial ureteric fistula. You see? So not every cause of the bleed is from the kidney, and angiographically negative, you have to really pursue what's the other cause of the bleed. And not infrequently, if you put them on some transamines or vitamin K, you correct the coagulopathy, you give some plasma, they do settle down. And one thing I also learned from our experience that earlier we were mentioning about cordyceps and decoagulants. Here you try to stop bleeding, there they consume all this to stimulate more bleeding. So these are various compounding clinical factors we have to look into before you whack the kidney with gel foam.
Yeah.
Thank you.
Yeah. Thank you.
Any other comments?
Okay, thank you for your presentation. About my experience, we have a series of cases of AVM kidney. Sometimes it's very difficult to do the embolyze, particularly with the kind of schizoid AVM. It means that so many branches to come to the AVM, and sometimes the patient with the immaturity, we have to do embolyze. If we do embolyze, it means we lost much parenchyma of kidney. But what do you have any experience? Because sometimes it's very difficult.
Yes.
Some coil like that, I think it's an easy case. In some cases, you know, the kind of schizoid AVM. It means that you have no branch, so many small branch to come to the AVM. It's very, very difficult.
Yeah, I don't have much experience, but however, we can try to embolize in many times. Don't try to occlude in one time. In one time, in most of the cases, you lost a lot of parenchyma. And another material, another embolic agent we have not yet performed is alcohol. In case of the huge arteriovenous malformation, you can try alcohol. I don't have experience, but I heard about that. So maybe you have some experience.
Yeah, that's it. I think renal AVM is one thing which is very, very challenging to do technically. Number one is your kidney is floating in the sky. Number two, the feeders usually are very, very tiny and very difficult to cannulate. Invariably, you're lucky if you finish 1 hour, you're unlucky 4 hours on the table. What I find very challenging is that, number one, once your catheter is, your guiding catheter of 5 French peripheral rather than 4 French, park in a stable position, you use your micro catheter in to search for the feeder. And nothing bigger than 2 French. 1.7, 1.8 a better choice to go. Go in selectively. What I do is a 3 cc merit high pressure syringe. You do DA acquisition rather than DSA. This is 2 things. Number one, when a patient, the kidney is moving, your DSA will not show you the picture very well. You do digital angiography rather than DSA at 7.5 power per second. Subselectively, segment by segment. Invariably, you find where the feeder coming from. Then from there, you work your way in. Okay, I would prefer a 0.14-inch neuro guide wire rather than a normal guide wire, which is too hard. And track that. The moment you can wedge into the feeding pedicle by 5 mm or 3 mm, you can safely embolize. But the next step is embolization. Is very challenging. Is that you push too hard, it reflux. You push too slow, it blocks too early. I would usually start with alcohol, right? Alcohol, you take with the pidol, 60 to 70% is good enough. Don't use alcohol, you occlude too maturely. If the alcohol fail to occlude, next one you use glue. Very diluted glue, 25 to 30%, where you can give a very good deep penetration of niluses, as well as to prevent premature kind of like adhesion or stucking of your catheter to the pedicle. If you use these two gently and take your time, be patient, don't book another 5 cases behind that. Most of the time you can get it done. From my experience, if you are able to wedge into the feeder, within 2 or 3 pedicle, you are able to complete the job in most instances. Okay. But sometimes you may need to take off a small segment of kidney parenchyma, maybe 5% or 3%. Not a big area. You go super selective, you combine alcohol or hystericryl, and if you achieve the cannulation of the nidus, you will be successful.
What is your experience to perform the embolization with alcohol? How many milliliters?
Well, what I do is that you go by the opacification of the nidus. When you do the injection, okay, it depends on your angiographic system. I'm blessed to have a very high-end Toshiba Angio CT system, and you will see that my monitor is not the new super duper 56-inch LED monitor, which is look very nice. But honestly, coming to this details, low contrast resolution and micro catheter visualization is very poor. My experience previously was that we have another hospital whom we bought the same Toshiba Angio system, where I was struggling very hard to see a 2 French micro catheter, right? We high. Usually I use low flow rate, okay, low flow, low dose rate. I couldn't see, so I up to the high flow rate. I still cannot see, but my radiographer was laughing at me. Why you cannot see? Apparently they are looking at the back of the other end of the screen where the radiographer is controlling using the normal 17-inch monitor. They could see very well and clearly. Whereas I using about the so-called more expensive monitor, I couldn't see. So my new angio system, okay, essentially is using the conventional 17-inch monitor. And I could work very, very well and precisely on what I'm targeting without much difficulty. So you look at, depending on your angio system, you are able to see very clearly as you inject. You can put 7.5 pulse per second flow rate, or you can use a higher flow rate, but not too low flow rate, 7.5 to 15 pulse. As you inject under normal fluoroscopic mode. Okay. Alternatively, you can use digital angiography system, DA mode at 7.5. As you inject, it don't push, gentle, gentle. You can see filling up. If there's some crossover, not to worry, not to get panic. 1 or 2 drops is okay. Stop a while, then continue to inject. I would say a renal AVM would not consume more than 1 cc of your 66 or 70% alcohol. Hard day. Most of the time, 0.2, 0.3 cc, we are done. So, overzealous injection, too fast injection, too much injection is bad. I want to share an experience with you of another patient, which was done by another colleague, where it was a small AVM. They injected, I think, 7 cc of alcohol. Okay. In the end, it cooked the whole kidney, because as you inject, and you especially you don't opacify with the pylori, it backflow. It backflow to the normal kidney, and you don't see. And one of the indicators is that if you inject the alcohol into the kidney or any organ, and the patient is comfortable without pain, don't complain, don't yell, you are in the pathological area. Whereas if there's a pain, that means a reflux of the kidney or the liver, then they jump out of bed. Pain is an indicator that you have hit the normal parenchyma. These are little kind of like tips and tricks we follow to make sure you get a good result. I think if you spend your time with a renal AVM, you can actually get very good result. Noni, you want to comment something?
Maybe my strategy is the same as Alex. Usually I use a 1.5 microcatheter, very thin microcatheter, and select as many filling arteries as possible. And I use a glue to fill the nidus.
And in case you inject alcohol, do you perform the balloon occlusion during the injection?
No, you don't need to. If you go super selective.
Okay. I just have one more comment about. I would like to sharing my experience to use absolute alcohol to treating for renal AVMs. The same thing like you. I had to go super selective with one boy, like a neurointervention catheter, because it's very sharp and easily to approach the target. It should be as close as possible to the nidus. And then when you inject, before we calculate for the alcohol volume, we have to inject by dye, and we will see how much dye will fill up in the nidus. We can calculate it, and after that we just leave everything like that, because dye is still inside the microcatheter, and then we will wash it out until it's wash it everything inside the microcatheter. Don't try to push so much, because we can check it again. It's gonna be like slowly embolize later on. Don't try to push one time with very much absolute alcohol, because it's gonna be go back, retrograde, go back to the other normal, and it's gonna be closed up the other normal area. So I think so.
And for the follow-up, what is your experience? For example, if we have to perform the second time, the third time, what is the distance between the first and the second in case of the alcohol?
For renal AVM.
Yeah.
See, the thing is that when you treat this disease, you have to remember one thing: you are treating the patient. And essentially, I will always tell a patient, no doubt, most of the time I cure them. I always make sure the point carry through. AVM is a complex disease. What we are treating is what we can see. In long term, some will come back. But if we come back, if it doesn't give you trouble, it's always better to live with some imperfect DT rather than a perfect embolization. We can always take it off by whacking off the whole segment of the kidney. But I would see if whatever is left over is minimum, not much, and follow up after 3 months or 6 months on a CT angio, it doesn't really show much recanalization, and patients very well, no signs of bleeding. I just wait 3 years, 5 years, 6 years until the next session. If it shows some symptoms or you see that it's growing bigger, then you go in. So don't jump back on them too early. You know, it's just like this body AVM. You're treating a symptom. You don't treat the disease. Okay, you can never clear them.
And in case the volume of the malformation is very big, and is there a limit of the volume of the alcohol you can
Well, if you have a big AVM in the kidney, then you should think of us a surgeon to cut it out. Honestly speaking.
Yeah.
I believe there was a very active and a helpful discussion. Let's a little bit cool down. 20 minutes break. Thank you very much. Okay. Hello. Last session before nice dinner tonight. Please come back. Tofu. That's it. Is it yours, right? Yours dishes. You are the speaker. You are the speaker. Just briefly mention I'm going up.
Thank you for coming back. It's me again. For next 20 minutes plus, I try to keep in tight. We'll talk about the total control of the critical lesion, especially dangerous vascular lesion using coil. The landing point for this short session will be mainly on the role and indications of embolization, device stock preparations, principle and teaching in coiling, planning strategy in high risk and dangerous lesion, and most importantly, we are learning from our mistakes and each other's mistakes, and we will try to avoid all this, and I will try to make it an interactive sessions with questions. Let's look at this. I always believe learning from mistake is important. This 53 years old female post-transplant kidney had post-biopsy bleed. The biopsy was done by nephrologist, and nephrologist inserted the nephrostomy catheter with persistent bleed, and the bleeding was not controllable. The creatinine shot up to 150 micromole per liter. Okay. Embolization was requested. She was transferred down south to KL from up north through ambulance for a distance of about 400 kilometers. And interestingly, look at this. A diagnostic radiologist was on call, took the patient to the angio room, did an angiogram, okay, and this is what she found. She used a 5-French C2 crossover from opposite side, cannulate the renal artery to the transplant kidney. This is the angiogram, okay. Can you see the fistula? Well, we can see early opacification, the renal vein definitely is there, but where is the AV fistula, okay? Will you embolize that? Do you put a coil in A, B, C, D, or nay? No. We'll come back to this later. All right? Anyway, the coil was dropped by the memo radiologist, and it was obviously wrong vessel. The fistula is still actively looking at us. All right? Creatinine shot up to 600, fluid overload 18 liter, and patient need dialysis. Disaster. Let's look at another case. This is a patient, another young boy, okay, with renal transplant, and on the ultrasound detected AV fistula, huge AV fistula with peak systolic velocity of about 367, and attempted embolization by a junior trainee radiologist. The senior went OC, so took the angio room under GA, put the catheter in, and see how fast it's a shot. And superselectively cannulated with a microcatheter, and it attempted, and this one at least good enough using a detachable coil. This is a neuro coil, 5M neuro coil, and the coil was swinging away, and they put a occlusive balloon, try to coil again, it did not work. So, sorry. Field embolization, instead of abandon, he injected glue. Okay, abundance because on table lung embolization, desaturation, post-procedure sepsis, glue, the beta-lactamase, E. coli in urine, and further deterioration of kidney function. Treatment: the patient was treated with IV Mirarum for 2 weeks. Repeat urine, FME 3 weeks later was clear and sent for repeat embolization. So in these 2 cases, the radios is to be short. 2 things. Number 1, the principle of embolization is completely wrong. Number 2, do what you are trained to do. Okay, this is not their job. Okay, coil in the embolization of vascular abnormality actually dated back in 1975. A rudimentary coil was already developed. Manually cut the guide wire, or your 035 or 038 wire. You just cut it, take out the center core, roll it out, and push it in. It does work in many situations. Okay, and they have original coil. This is a handmade guide wire sheet. Then the mini coil, smaller, half the size, and the new coil, which are supposedly very advanced in those days, in 1980, of course, that are rudimentary, and those are pushable coil, pushable, you drop wherever it is, and in this case, we replace the optic artery. They want to do intra-arterial chemo infusion, and mind you, this is 1981, so they drop a coil at the origin, and the coil forward the superior mesenteric artery. No room for you to do anything unless you slant it out. These are the rudimentary coil where they fold back the coil, and there's no detachable mechanism, just push it out. And these are those old generation of coil, and these coils are still available currently commercially, and with appropriate usage and selection, they are quite safe. Okay. So the advantage of therapeutic embolization in the way is simplify and improve treatments of many conditions previously managed surgically. Minimize patient discomfort and traumatic recovery, especially with a pinhole incision, local anesthesia, and the preferred choice of treatment being less invasive or minimal invasive. Yes, lower morbidity and mortality. It decreases length of stay and hospitalization costs, safer. You don't need general anesthesia. Many advantages. And the role of embolization also encompasses 3 main subcategories. One is replace surgery, to complement surgery, and as a palliative procedure or condition for a condition with no surgical solution. This obviously is one case usually managed surgically. Massive bleed. Rush from another hospital after 16 pints of blood. Projectile vomiting of blood in the ER with an intubated patient, rush to angio room immediately, and up and down, all pouring out blood. And failed medical treatment, and can't even do a scope because of this, and we took the patient to the angio room. On the table you can see actively pouring gastrorenal pseudoaneurysm, which was coil, and immediately the bleeding stopped. Right? We use pushable coil. My fault, because you see, there's a coil tail coming back. These are situations where, when just pushing hard to stop bleeding, we didn't have much time to think of getting a detachable coil at that time, right? And the indication of embolization are many. I think these are in the principle that we should, in the interest of time, we bypass these slides and I run all kind of embolic agent as an IR, or you want to embark in the field of embolization. You have to know every of this single product, indication, property, contraindication, and usage very well. Coil, there are many coils. Most of them are pushables, some are detachables, and there are 3 techniques essentially in the deployment of coil inside the vessels. The standard technique is just push it in, right? Make sure the size appropriately, choose the correct size, push it in, and just drop it there. Or second one, in the high flow situation, those days without the
the detachable coil system, we do anchor technique. You find a major side branch, put a catheter in, start with a coil deployment and pull back and loop around it. Hopefully this little anchorage can hold the coil. Most frequently in a very high flow system, they are not. That's why it's pretty dangerous if you choose the wrong technique in the wrong place. The third one will be scaffolding technique, where you upsize the coil about 50% more or 60% more, put a bigger coil, then slowly you pack, push in and out, and pack. You hope that it stays. In the high flow situation, and honestly in most instances, it is actually very hard for you to just put a coil stay in that position. Invariably, as you deploy more segment of coil, it push forward. So this is another thing which is pretty dangerous if you do not use in the correct location. The conventional coils are pushable coils. You deploy once push out the catheter, drop and go, unpredictable final position, and incorrectly placed coil can cause serious complication and hard to retrieve. Okay, delivery is coil pusher. Use coil pusher, or you can use saline flush technique if it's in a safe position. Do not use your normal wire to push a coil, because a wire usually is smaller than the diameter, inner diameter of the catheter, and there is a dead space where a wire will pass between the coil and the catheter, and everything will stuck. You have to pull out the whole system and reinsert your catheter again. This is just the case earlier. Luckily, it's only about 1 to 2 mm. It did not cause any major flow limitation. We waited for a while. It settled down, so we decided not to retrieve it out. Detachable coil enable more controlled coil embolization, and it is repositionable, which is very important until you are satisfactory. You are satisfied to reach a final location. You can do all kind of manipulable technique. And the indication of the embolization indication, which precise embolization is critical, and especially in high flow vessel, and embolization close to the origin of the vessels, like the gastrorenal arteries in the circ, or hepatic arterial infusion system, or in aneurysm where dense coil packing is desired. Okay, this is a patient with advanced HCC. We put a arterial port in the left axillary artery, and the catheter packed in the right gastrorenal artery with a hole in the common hepatic arteries, and you really need this precision. This is where IDC come very handy. And interlocking coil, the detachment technique is just like GDC or other neuro coil. The only difference is that it is interlock. It's just a catch here. You do not diatomize, or you do not use other mechanism to detach it. The moment you push it out, it drops. Once it's out, then you can pull it back. And this IDC 18 again, and different size, different shape, different configurations, and length as well. In the principal embolization, the technical pitfalls include clinical indication and evaluation. You have to have an appropriate clinical case selection. Don't be cornered by a consultant. I want you to do A, you do A. You want to do B, you do B. But you have to stand on your own feet. No, this is not appropriate. Something else may need to be done rather than follow what they want, because they are just putting a request. They are not in no position knowing the technical detail. I always tell my patient who come for consultation, doctor, that surgery is safer. What's the complication, right? Will I recover? Will I be cured? My answer is, I don't know. This is not my procedure. Ask a surgeon who's going to operate on you. That's a safer way to go about. In-depth understanding of the principle of embolization is utmost critical, and know your target endpoints. The two cases earlier I illustrated just show that a lot of them do not even understand the principle and start to whack around. Back to this case again, okay, right? Drop in that branch, which is a normal branch, block off a last segment of the artery. So we went back in super selectively, and then we found that actually the fistula was up here, which was up there, right? And with a few pushable coil, that time, I think this was in 2001, the IDC was not available. I have no choice but to take a risk of using pushable coil. 220. Nowadays you relabel it differently, there's a big confusion. I still stay back the old labeling 220, 330, 440. That will actually give us a perspective of what type of vessels, what's the diameter of vessel. And even that, you see, one of the coil has a move over. Okay. And with that, we completed embolization here, and this is a coil dropped by the memo radiologist. And the patient recovered quite well. Creatinine dropped back to 154, and she was off dialysis. So precision is very important, okay? And let's talk about technical pitfall again in terms of the embolization. You want to target a nidus. You don't want to hit the artery too proximally, because if you just, like in this case, the last pseudoaneurysm from intramuscular injections in a young child, if you block proximally, the corrector will set in. So we really need to block the back door, then only come back to the front door, and this will achieve complete occlusion. All right. And another patient, rectal bleed in the patient with Crohn's disease with a pseudoaneurysm of the superior rectal arteries, where we have to really block both sides to achieve the control. Another patient, this is inferior pancreatical renal arcade in a 35 years old patient with ESRD on dialysis, acute renal bleed from the ulcer. Based on this, where will you drop your coil? A lot of people think that, I must be here, so you drop a coil here. In situation like this, you really need to go into the artery which is bleeding, peripheral point source bleed, because the corrector will come in. You see that we really go into that point, right, and double block back door and front door. Only we achieve the embolization. And usually do a few oblique runs to be sure that we are in the correct vessels. Otherwise, if you just block here, in any block wrong territory, it may cause major complication. The other principle involved is be stable guiding system and catheter support. You must prevent backout of your guiding catheter or microcatheter during the process of coiling, because as you embolize, the resistance will be out. This is a patient with large right common iliac artery aneurysm and a bilateral iliac artery aneurysm with abdominal aortic aneurysm. So this is a aortoiliac bifurcated stent grafting with the iliac branch graft. The left side, this is the iliac branch graft, and right side we have to really sacrifice this and close off this aneurysm and stand across. You can see that the resistance will build up. And my colleague also with me, they say, just put a microcatheter in, start to deploy, then we do the job. I say, no, we really need to have a very stable and strong guidelines, otherwise we get stuck. So enough, as you go in, you see that as you come to the final bit, everything's falling back, and without a strong guiding system, it will back out. So strong and stable guiding system is the key for successful intervention in most instances. The indication of the detachable coils are lesioned when precise embolization is critical, like in this situation, in high flow vessel, like the second case we show you, embolization close to the origin of vessel, and when aneurysm, when dense packing is desired. This is a patient for circ, where precise embolization is necessary. You can see that this coil is really prolapsed back to the proper hepatic artery, where we had to snare it out to achieve the good result. And this is just diaphragmatic the illustration from Boston Scientific of importance of precise embolization using detachable coil. Okay, this is a patient with huge AV fistula from the renal biopsy 20 years ago. A 42 years old man, and this is in 2003. A lot of technology was not available. I would say that the young IR nowadays are blessed with all the advanced devices. Where those days we had to really think of MacGyver how to sort this problem. This patient presented with deteriorating renal function, creatinine 245. The right kidney is not very good. Left kidney, what we are seeing is this big AV fistula with the feeding artery is 14 mm. This pedicle is 14 mm, okay? 14 millimeter size of aorta. This aneurysm is 4 cm, all right? This fistula with aneurysm 4 cm. What will you do? In 2003, how are you going to do this? If you take the patient to theater, the only solution, nephrectomy. Terence, what choice do you have? More selective. You put your catheter until here.
Can you show the run again?
And this is at 15 pulse per 15 frames per second. You see that the renal cortex is not outlined at all. Quite like the patient, the second patient I show.
If you occlude the outflow, will that help?
Your outflow is, this is easily 5-6 cm, the outflow venous side.
Ask for help.
I was alone. Anyway, I just want to play safe. You see that I put a catheter in the venous side, and that's a renal vein, and another catheter in the arterial side. I want to have this very strong scaffolding device, okay? Then I actually have a guiding catheter this end in case I need to quickly shove a balloon out to blow to protect it. And anyway, from here, from the arterial side, we float a 14 mm balloon. Flow control, inflow control, like the other patient, okay, the second patient. The IR also put a balloon proximally try to control, but the balloon was too small, 14 mm. Then we insert even those days we have this Jackson detachable coil, something like IDC. These are 035 system, Jackson detachable coil. We screw on and we detach, unscrew, okay. And this is from Cook's. We inserted all the coil and flow by 25% hysterectomy injection. It was completely controlled, and this is how we get a result. Proximal control, adequate the coil mass scaffolding device followed by hysterectomy embolization, completely occluded, only pull out the whole system. It worked very well. Okay, this is what we should follow, and you see that the renal cortex actually returns. And this is chronically kind of like ischemic, so but after some time the kidney function back to normal. How about this aneurysm? Dissecting aneurysm in the distal main renal artery. I think, of course, nowadays we have many technology. Those days we had no choice, but then still with a balloon occlusion technique with GDC, we managed to control it. So this is where the detachable coil system come very handy. You really need to have this the capability of controlling the coil for you to finish the packing. This is before, this is after. Okay. And on the other hand, cardiac aneurysm sometimes go beyond what you are seeing in the bronchiectasis. Okay, very extensive, massive bleed, 3 pints of blood given already, still pouring away. When you do bronchial artery, bronchial arteriogram, you are seeing this aneurysm here. Okay, and major opacifications of the pulmonary artery. These are what we call Rasmussen aneurysm, typically in TB. And if you embolize from the transarterial side, most of the time you will not be able to actually target. But instead, if you go through a pulmonary artery and selectively embolize off, block it off completely, and then you achieve your endpoint. This is another type of the aneurysm. You really need to target it appropriately. In this situation, maybe the use of detachable coil may not be that critical. How about giant splenic artery serial aneurysm? Again, the principle here, front door, back door. Okay, we have to control the back door first, which is outflow on the other side. Okay, it'll make, I think, many turn to achieve the crossover the other side. I think the picture doesn't come out as good as on the computer. Anyway, we difficulty manage to cross to the other side, the other run off is 30. Then again, you want to optimal control, you prefer a detachable coil system, IDC in this instance, IDC in 2 coil in. Then I inject large pieces of gel form torpedo, right? Because if you inject historical, you probably use up 10-15 bottle. Okay. Essentially, if I block the outflow, I stabilize the aneurysm with gel form, then I block the inflow with additional coil. You see, this already slowed down with gel form torpedo. With additional detachable coil in front, then you achieve control. Okay. So again, detachable coil is critical in this situation. How about this patient? HST massive hemoptysis, third episode, first episode in 1992, and he was the world's second pulmonary AVM embolized in Hammersmith when the JDC coil was first invented in 1992. The second volunteer. In 2011, secondly rebleed again, and 3 coil was inserted in the home country, and patient was prescribed on 3 things. You have to go on lifelong transamin every day, take transamin tablet, 500 milligram 3 times a day, and no exercise for the rest of your life. Okay, and of course you can't take any antiplatelet even though he has ischemic heart disease. So that you can see, but here now you cannot see. But the CTA you can see there's some coil there, right? And the AVM still there. And these are some 3D illustration of coil there. Okay, and you can see the coil loop actually is quite loose, right? See that the coil loop was very loose. The second embolization, only 3 loose coil was inserted, I think, and because of that, the primary principle of embolization or AVM it's already failed because loose embolization without complete occlusion. Right. I'll put aside the further recanalization after coil compaction. Anyway, we went in super selectively, IDC again, see that the coil is bucking out, your catheter has to be very, very stable, still bucking out. With adequate manipulation, you should be able to get it in, right? This is the last coil you put it in, all right? And I noticed that in this type of situation, if you just use pure coil and pack, cost is one issue. Second thing is that it doesn't preclude further the coil compaction recurrence. I would usually in situation like that, I add in a little bit of hysterectomy, 25%. So I have a solid framework of coil and additional embolization with this glue. So, and I noticed with this combination, the place you embolize is hardly come back. And also not to forget, you have to check for other collateral. See that there's another one here, small one there, and in this situation it's easier. In order to save money, you just drop one 330 pushable coil, and this is 330 pushable coil, and I am not worried that it may fall back here because the situation is in control, and a small amount of hysterectomy injection to cover up the rest. Okay, that's with hysterectomy, then I achieve 100% occlusion. So the principle of embolization is that you must achieve adequate occlusion or dense occlusion. You must take care of collaterals, and I think my picture has gone off. Okay, that's back. Okay. This is complete occlusion, and this is confirmed, and we follow him up after 3 years, and the CT scan did not show any recurrence. The use of vascular plug is important in situation when the artery is very big, very huge, and the shunt is tremendous. Okay, in high flow vessel, large defects, etc., and the vascular plug. One thing, the shortcoming is that in a very tortuous vessel, and if the length is not enough, the length of the place you're going to drop the plug has to be 3 times the length of the size of the plug, yeah, because it comes stretch out and then it deploy, it becomes shortened. So not every case you can use a vascular plug, but there are other solutions which I'll share with you later. This patient, 55 years old cardiologist, case of Ehlers-Danlos syndrome, had renal stone removed, okay, 9 months earlier. But the shear guide oil perforation, after 9 months, he came down with such an extensive AVM, the AV fistula, huge one. And he was actually told to have a kidney cancer of 9 centimeters and prepare for surgical nephrectomy. Last minute he came, and for a second opinion, we realized that actually it's AV fistula, huge AV fistula with large aneurysmal sac. Okay, this is the ultrasound. Sorry, this is post embolization. Where are all my picture? Okay, again you have one like this, and what will you do? Well, my fault. I didn't prepare a vascular plug. We thought we go in, you use a balloon occlusion, then you can coil, right? We went in, we tried to coil with the double catheter technique, tried to use an interlock using 2 IDC to kiss each other. But these 2 coils, instead of kissing each other, they're swimming separately into 2 separate directions. No way, okay? And with balloon occlusion technique, it also did not work. Okay? Essentially, the flow is just too torrential that no device will stay. So finally, we had no choice to summon in the vascular plug. This is after deployment of the plug there. The important bit is that we have long segments of the feeding pedicle which allow us to put the plug quite comfortably. This is So once a vascular plug is in, it acts as a scaffolding for us to drop more coil, right? More coil. Just insert 4 or 5 more coil, then followed by again we use the glue, 25% glue is completely occluded. Okay, this is immediate angiographic result, and I follow him up for 2 years, no recurrence. He's very happy. So this is the current Doppler after 6 months. The sac is resolving. So the principle is that we really need to have all the stock available, otherwise we fail on that table. And if I inject glue, I would definitely land with trouble. Back to this patient, okay? 4 years old, 16 years old boy, transplant was 4 years ago, and detected strong bruise. Initial ultrasound says the renal artery aneurysm, but on further evaluation, it was actually a huge AV fistula, EGFR 45. And he was planned for coiling or renal artery aneurysm, but obviously it had changed planned, and because the final diagnosis is the AV fistula. This is a Doppler I've done before they actually went in for the angio. The peak systolic velocity is about 345, and this was the picture I showed you earlier. They attempted the coiling, which failed, and proximal flow control also did not work. And she came down with this sepsis and beta-lactamase UTI. So what will you do in this situation? Any suggestion from the floor? The fistula is about 7 mm. Dr. Low? Well, you see, the thing is that when you go more selectively, there are many branches coming out from. I know this artery is pretty long. This is the one which is going to the fistula in the lower pole segment. This is toward the upper half of the kidney, lower half of the kidney. There are a big area of the renal cortex here. If your vascular plug, number one, you definitely sit along this segment. Your sacrifice of side branch is too severe. And second thing is that for vascular plug to go through this tortuosity, not only you have to advance your guiding catheter to that level to deploy it, it's also quite risky. You may just dissect renal artery. So, in my personal opinion, vascular plug is not a consideration in this situation. Any other suggestion? Terence? This is the last case, no worry.
Could you put up a balloon and slow the flow down and have a better look?
Where will you put a balloon?
Up in the renal artery.
Yeah?
Maybe a bit back.
Back a little bit, then slow down. Now what are you going to use to embolize?
See if you can identify all the feeders and then go very selectively and coil.
Yes, I fully agree with you. In this situation, point source coiling at the site of the fistula is the primary aim of treatment. Anyway, this is on selective cannulation. You can see that, Dr. Loh, there are a lot of branches coming out here. See that? This is where the fistula is. A lot of branches coming out. Our target is we do not go beyond the origin of this branch. Okay. Anyway, what I did was that super selectively cannulated this. Okay. Of course, in this situation, you should discuss with family before the procedure whether surgically to clip it, which is impossible for the surgeon to reach. Whether you do coil embolization, historical embolization, or balloon embolization, detachable balloon, for instance, or hybrid embo. I think the projector is a bit too contrasty. Anyway, what I did is that this is earlier, remember this was earlier what they have done, okay? I put one guiding catheter into the renal artery. This is a 6-French neuro guiding catheter. Sorry, this is in the renal. This is in the renal artery. Another catheter into the renal vein. Okay. My intention is that I'm going to occlude the artery from this side and coil from the venous side, transvenous coiling. Okay. I use a gold ball tool, detachable balloon, but the wonder bit is that the moment I inflate this balloon, the fistula has completely stopped. You see that the normal fistula. Okay. So I just want your opinion here. Do you stop here? Just detach the gold ball balloon, come out, we are done. Well, I think the patient come in, this is the second session in angiogram. One way or another, we have to ensure no recurrence. These are cases where we can be very sure that the patient will not come back if you do appropriate thing. And this balloon is, it will deflate by itself in a month or 6 weeks. And this is a 7 mm hole fistula. The moment you start to deflate, the blood flow will return. Then you act a recur. So by hook or by crook, you must close off this. You cannot take the risk of deflation and recognition. Anyway, my catheter, everything is there. It's on the transvenous side, so we just push in the 5 mm axiom coil. Okay. This is completely occluded, and on table, complete occlusion. You see that the perfusion to the lower half of the kidney has returned. So with this super selective and precision coiling, we have actually avoided any elements of renal ischemia or sacrifice of renal cortex by combining balloon and coil. Okay. These are things which is we can combine in many situations. Combination therapy actually work out very well, and this child has a full recovery. So the learning point here is that proximal flow control and the high risk paroxysmal embolization using liquid embolic is very dangerous unless you have the scaffolding to hold back the glue. Okay. And you must target the source and nidus, and transvenous access actually offer a lot of advantages in many situations. Okay. So this is the last slide for the session. The learning point is that planning strategy, proximal flow control, device stock preparation, never do in a small center. You must have your team to be with you at all time, and you have blood in reserve, and definitely not for a beginner. So these are the things which is I would like to emphasize, and even I would have to admit, for me, sometimes I also got caught in a tight shoe. I just would like to request 5 minutes for some promotional activity. This is just my angel room. You see that all the monitors are conventional monitor. Two good things, cheap to maintain. One unit spoil, just change the unit, because the LED monitor, it costs 100,000 USD. This is only about 6,000 USD. Okay, and handling complication, the IR has to be ready to handle complication. This is very early days, I think 1998, where the coil fall back to common hepatic artery, where we had to snare it out. Okay, I just would like to do a bit of advertisement for the upcoming meeting next year, the 6th Asia Pacific Conference of Interventional Oncology 2019, which will be held in Kuala Lumpur in the KL Hilton. And these are the dates. I think we have passed around this boarding pass around, and we'd like to request your participation. And before that, we just want to show you what we have done last year as kind of like event, and this is going to be 3 times the scale of what we have done. This is one of the video clip to emphasize the importance of multidisciplinary collaboration. And this is a video clip during the event. We are expecting the event to be 3 times of this scale. the Congress highlight, we cover these 12 sectors where, more importantly, we emphasize on the future precision medicine in the interventional oncology. We're going to put a lot of emphasis on hybrid treatment technique using angio-CT guidance, state-of-the-art transarterial therapy in the management of cancer. Not to forget taste beyond the liver. This is what we should embark on, and this will also bring in big new adventures as well as scope of services in the field as well as for the industry. Look forward to have more businesses from this aspect. And we also have live telecasts and masterclass programs, and these are something which we're going to have the 4th masterclass in taste again, and things like this will be emphasized. And we welcome you to join us in the participations, and the invitation we send out to the whole world, especially Asia Pacific. Every country is covered, and every country will be invited to send in their national speaker. The organizing committee, we try to cover certain amount of cost. And we have another 2 things which is coming out. One is young IR support or perhaps scholarship. Those who articles or free paper has been accepted. Either be those really good ones, we put out the stage to give a presentation or oral presentation. Alternatively, with poster presentation or electronic poster presentation. We are targeting to support about 60 young IRs for the event. Okay, with significant sponsorship from the organizing committee. We also have another group of the sponsorship for those countries who have financial restrictions. Okay, will be the repeat of 2008 APCC. We are again 1,000 USD to cover 2 delegates covering the registration and 3 days of hotels stays on the twin sharing basis. So that is the lowest we can go, and we hope to welcome you. Definitely we send in the invitation for the national speaker from Vietnam. I think I put Vietnam is one of the priority lists because looking at your development of interventional oncology is very tremendous. We want you to come to share with us your experience and present more paper. Put yourself in the world stage. The APCIO committee would like to profile this is one of the world stage performance at par with ECIO and SIO. We will be there very soon. With your support. Thank you.
Thank you very much for the presentation and the introduction about the Congress. And maybe we move forward for the last presentation by Dr. Terence Thiaw on the endovascular treatment of thrombolytic disease. And maybe we let's all the discussion at the end of the section or during the dinner.
Hello. Okay, so I think maybe we move the focus a little bit on endovascular treatment of thrombotic diseases in arteries and veins. Personally, this is probably my favorite topic because I love to do thrombotic diseases, and I will show you why. So this is how I outline my talk. I'm talking about arteries and veins, and for the arteries, we mainly the lower limbs, and the veins will be mainly in the iliofemoral area, which is basically below the diaphragm. Some important considerations prior to treatment and the aims of the treatment, and some example of cases and summary. Okay, some pointers starting treatment. Okay, I think the history is paramount. It's very, very important, especially with the onset of symptoms. And as an operator, the person who's doing it, we need to decide what we are trying to achieve. We need to treat the arteries and the veins separately, okay? The arteries are not thickened veins, and the veins are not thickened arteries. They're completely different thing altogether. Embryologically, they're different. The gut wire field when we are doing this procedure is extremely important. And for those of us who've been doing IR for a while, you know exactly what I mean. And there are many things that can be done. Just just not just endovascular, but also for medical therapy, anticoagulation, which is what a hematologist will all want to do, surgical therapy, which is open embolectomy, and what we can do in endovascular. So what's the traditional endovascular option? I think most of us will be quite familiar with this. Get the venous access, crossing the occluded segment, whether it's an artery or vein, start a thrombolysis catheter according to local institutional protocol. Some people use RTPA, some people use urokinase. It doesn't really matter, although I moved towards RTPA just because it is cheaper in my institution for some reason, which I do not know why. You may want to give some heparin via the sheath side port. Unfortunately, the patient then you need to stay in the ICU or high D and not in the general ward. They need to be monitored quite closely because of the risk of bleeding. This patient needs to have scheduled blood tests done, which means that they get poked multiple times during the time that you are looking after them. You need to have a check thrombolysis, because after partial thrombolysis or full thrombolysis, you need to bring down and see the results of your work. And then you decide whether you want to continue thrombolysis, which means that you need to open a new catheter, or you need to undergo some more adjunctive measures like angioplasty or stenting, and then wash and repeat. Means that depending on what you see, you repeat the entire procedure again. Patient goes back to ICU and so forth. So this is an example of a thrombolysis catheter, very similar to what it was before. This is the rate that you run it at, and then you run the heparin via the side port and so forth. And the target for your PTT is 2 times the normal. And then if you halve it, if your fibrinogen becomes less than 150, and then you halve it again, or you stop if the fibrinogen becomes less than 100, and then you do the check venogram. And this is, of course, extremely time consuming. Now, this is my preference personally. This is the angiojet system. It is a combination of pulse tray thrombolysis and aspiration. I'll explain that later on what that means. It is often 1 step or at most a 2-step procedure, but it is not suitable for all patients. There are also, to confuse things even more, there are actually multiple types of catheters with different indication depending on the size of the vessels that you're trying to treat. There is a timing and cycling limit to use, which means that you cannot continue using it forever, because you only can use up to a certain period of time before the patient starts to develop arrhythmias and hematuria. And this is not just 1 step, because adjunctive measures are often required. And to make it really, really simple is to have a 2-man operation. 1 person to push the catheter, 1 person to pull the catheter. And of course, there is cost consideration, although overall I think it is cheaper than the traditional method. So what's the angiojet system? The angiojet system is basically a simple catheter. It's a single catheter which allows you to power spray the your thrombolytic of choice directly into the clots, and then followed with using a suction mechanism to suck the softened clots out. Okay, so it basically uses the Bernoulli effect. The Bernoulli effect is also the effect that allows the aeroplane to fly into the sky. So basically, using that kind of technology, you're using a kind of principle, and the setup is extremely simple. The Pearl registry was started by the Angiojet company themselves, and this is just a very busy slide that says that basically many people have their own protocols. Okay. So what I use the Buzz and Lyse technique, which is basically you dilute your RTPA into about 150 ml of saline. You pulse spray it without aspiration, and then subsequently, this is probably the most difficult part of the entire procedure, you sit and wait for 30 minutes, and you do nothing. Then follow that with a thrombus aspiration. The pulse technique is where you use the high pressure jet to create a negative effect, and then you suck the softened clots out, and then you draw the thrombus into the catheter, and then the fragmented part comes out of the catheter. And then usually I try to do it as a single session. Basically, I don't want to bring this patient back and do a check. For the peripheral arteries, we look at the aim at the edge of the clot, and then the aim is to clear everything. Okay, you need to get really perfect results as much as you can. Although that it comes with the risk of distal embolization, which can potentially make matters worse. Just an example, 59-year-old Caucasian man with a previous right SFA stent and presented with recurrence of left lower limb claudication. I think this slide very clearly shows on the angiogram to the toes so as to make sure that I don't miss anything in the lower aorta. Am I missing an aneurysm with clots that's throwing things down? Am I dealing with a tortuous iliac arteries? Can I do a over the hill, or can I just do a downhill puncture? So just doing a CTA gives us plenty of information. And when you do the CTA and when you see on the angiogram, it's really good pictures. You can basically help you in your planning. And in this angiogram with the catheter going past the area of occluded segment, you do a lower angiogram, you know that this patient's main vessel runoff is only via the anterior tibial artery, because you can see that the arches of the foot are well formed. There's good collateralization, and there is also digital artery opacification. So after you cross it, and then you bring the jet up and down over the occluded segment after you lyse it with some RTPA, then that is when you start to see all the unmasking of the underlying lesion. Okay, it cannot be possible that the entire artery from the bottom of the stent to the tibial peroneal trunk is completely occluded. It's just not possible. There must be some underlying issue that causes it to completely block off. And once you remove all the soft clots, then when you see all the hard plaques. And you can see very clearly where the 3 arrows are, the areas of the offending lesions. So you need to get rid of all these lesions, all right? So once you get across that, you buzz up and down, and then as we showed there was some inflow, we bring the catheter down on the first picture on the left-hand side. You can see that once you do that, once the flow improves, you start to see more collaterals. You actually can see that there is more opacification of the collaterals. You can see that there is a filling defect within the tibial peroneal trunk, and there is some kind of distal recanalization of the peroneal artery, although the posterior tibia is completely gone. But as with most things, unfortunately for this patient, very quickly the entire occluded segment, which we just RTPA and did a pulse spray, it got occluded again. And fortunately or unfortunately, these are again very soft clots. We go back and thrombectomy again with mechanical thrombectomy, suck out all the new clots which just formed. So it's really simple to suck it out. Do the balloon angioplasty and then see how is the result. Unfortunately, after you do that, some of the clots which was not completely aspirated out will fly off. And you can see again very clearly in the picture on the right side that the tibial peroneal trunk is now completely gone, where is the uppermost arrow. You can see that there are some lesions further down, but you also can start to see there's some recanalization of the other native vessels which is flowing from the collateralization. We started to jet a little bit of the clots which is above the stent, and then see where the lesions, again where the offending underlying lesions are. Balloon angioplasty, do the stenting, which are all the adjunctive procedures that we need to do. And then we do a drug-eluting balloon, which is just around the knee joint, and then voila, you get a nice re-inflow, recanalization of the entire occluded segment. This takes you less than 2 hours to do. It's a one-off. You don't have to put any thrombolysis catheter across. You do it well, and then you see it's a single vessel runoff, which is very fast flow. But if you notice something, what you notice on the right-hand side is that the flow to the foot is not as good as it was before. Just compare two side by side. You can see that the left-hand side, that was the one before we started treatment. And the right-hand side is after we ended everything. So what do you do now? Do you go and start chasing all the vessels? Okay, the answer is no, okay? Because you have no idea whether this is due to distal embolization from your thrombus, or this is due to distal embolization from your drug-eluting balloon. And very often we see this. This is really, we see this all the time. Don't panic. There will be a good pulse at the DP. There will be, of course, an absent pulse at the PT. But the patient's leg will actually pink up. Go clinically, you see that the toes, the capillary returns actually do improve. Leave it alone. Start the patient on heparin and your usual anticoagulation. And this patient actually did very well before the patient came back 2 years later with a similar symptom. So we managed to keep this vessel open for 2 years. Venous disease. For venous disease, it's slightly a little bit different. We'll want to make sure that the clots are really young clots and not something that has been there for a long time. The aim is just to re-establish flow and to prevent post-thrombotic syndrome. That means you're not looking for perfection. Okay, very different from arteries. You're not looking for perfection. However, the risk of distal embolization in venous disease is also not much of a concern, and I'll explain why later, which means that do you need to use an IVC filter or not? Personally, I hate using IVC filters. It is very simple to deploy, but if you happen to deploy it wrongly, it is impossible to get it removed. Okay, and then you need to treat the underlying precipitating cause, and I'll explain to you what that means later on. So now why do we need to treat all this iliofemoral DVT? Because there is a huge comorbidity associated with iliofemoral DVT. You don't treat them, okay, they will result in a progressive disease which ends up in a post-thrombotic syndrome, PTS, and PTS causes venous dysfunction, and this occurs to up to 50% of all patients with chronic DVTs, and the patient ends up with chronic leg swelling, heaviness, pain, and you can just imagine they have ulcers, they are unable to walk, they walk a little bit, the whole leg is swollen, basically they are bed bound or they are wheelchair bound. And because of that, these patients cannot work. If they cannot work, they are not contributing to the family income. The good thing about assessing PTS though is that this is basically nothing to do with imaging, right? It's nothing to do with imaging. Everything is to do with clinical symptoms and clinical signs. And then you just grade them one by one. So what is the evidence to treat? Okay, the evidence to treat is that if you have resolution at the early resolution, the morbidity at 1 month is actually quite low. But what we also know is that extrinsic compression stockings do not work, right? So for situation where your hematologist or your vascular surgeon say that, we can just go ahead and just put extrinsic compression, it has been shown not to work. Systemic anticoagulation is something that the hematologist, of course, loves to use with all kinds of stuff, which I cannot pronounce, and I have no intention to. They basically target thrombus propagation and not thrombolysis. So basically that would mean that they prevent the blood clot from getting worse, but the underlying blood clots needs to be chewed up by your white blood cells. And if you think about it, it's actually a very simple thing that we learned about it when we were back in medical school. Virchow's tried it. We know that thrombus happens when there's endothelial damage. We understand that there is hypercoagulopathy for various causes. Some is acquired, some are hereditary, and there's stasis. So what we are trying to do is that we are trying to prevent all three at one go, if you think about it. You try to prevent all three at one go. And you want to, in an open vein concept, you want to dissolve the clot in the acute phase. Okay, so that is to reduce the risk of more permanent damage to the underlying function of the vein, which means it includes the endothelium as well. And you want to preserve the venous valvular function, because once the PTS sets in, your venous valves are damaged, and then that will result in PTS. Okay, and once the clot gets chronic. Okay. What's the long-term outcome of this trial, the CAVAN trial, which is a very, very famous trial, is that when they do a catheter-directed thrombolysis and they needed to stent some of these patients, they actually do much better. There is no death, no PE, and there is no cerebral hemorrhage in this patient if you do that well. And then when they look at a long-term trial, when they look at it long-term, the patients also do much better than the patients who do not undergo a catheter-directed thrombolysis. In a torpedo trial, they have very similar results. They had to use stents, okay? And in the Apac trial, which was the biggest trial so far, which was published about, if I'm not wrong, about 1.5 years to 2 years ago, this trial, everybody was very excited about it because they were hoping that this trial will prove once and for all that PMT, which is a pharmacomechanical thrombectomy or thrombolysis, will be of use. Unfortunately, they didn't get that good results with this Apac trial. The reason was because one of the reasons or criticism of the trial was that when they found that they were a little bit way behind time in terms of the patient recruitment, they started recruiting patients which were not suitable for PMT to begin with, which was basically below the level of the groin disease. And a very small number of them actually underwent stenting, which is only about 30%, okay? But fortunately, there was no intracranial hemorrhage for this patient. There is some benefits in PTS as well as prolonged long-term follow-up, but there was more bleeding complications in this patient, of course, compared to systemic disease. Having said that, we are always trained as doctors not to look at pictures, right? Even that we tell that to our clinicians. So if you tell this patient who has a swollen left leg that I cannot treat you because the Apac trial says I cannot treat you, it's really not fair. Because in this patient, when you treat them within 1 month, the legs goes back to normal. It makes a huge difference. It makes a huge difference to that one patient that you treat. In fact, in some recommendations which was published before the Apac trial, various societies from around the world recommends that you can do PMT if the symptoms occurs within 14 days to 28 days, depending on which society guidelines you want to follow. When it's limb-threatening, when there's rapid thrombus, extension or symptomatic deterioration, if the patient is young, right, good life expectancy, good functional status, economically active, sole breadwinner, bringing bringing bread to the table, and when these patients have low risk of bleeding. Of course, when you have a competitor, which is from the respiratory physicians, who also give anticoagulation, they'll sing the opposite tune, and then they'll tell you that anticoagulation is better over catheter-directed thrombolysis. The next thing will be a talk about IVC filters. Okay, we know that from trials long ago that if you have an IVC filter in situ over a period of time, they in fact increase the risk of DVT, right? Rather than, it's good for the short term, but then it gets worse in the long term. Having said that, some authors actually says that if you can see on the CT scan that the thrombus is free floating or is extending from the iliac veins into the lower IVC, then putting an IVC filter is indicated. Some other societies recommend against a routine use, and then we have to take into consideration the relative risks and benefits of such a procedure. So this is an example of this really young lady. You can see that we put the IVC filter. It's in a relatively good position. You can see on the left-hand side that this patient has May-Turner syndrome, right? It's very clearly, you can see that there is a filling defect across the left common iliac vein. And this patient was very, very naughty. She's a young lady. She travels overseas all the time. Called her a few times. Can you please come back to have the filter removed? Okay, then don't turn up. And then 6 months later, just to see where's the tip of the IVC filter, you can see very clearly that the tip of the IVC filter is sticking out, or at least very close and endothelized into the IVC. So you can see from the first picture on the left-hand side, the arrow in the direction. When we couldn't snare the head of the IVC filter, so in the end we used a double loop snare technique. This was after about 2.5 hours in, 3 hours in, and then when we finally managed to get the hook of by some strange reason, we managed to get a hook of the filter. Pull and yank, and you can see in the third picture, the one that's bottom on the left hand side, you can see the tension in the snare. You can see how close the leg refuses to close, and then finally with a sharp yank, and you really have to have a big gallbladder, which means that you got to be very courageous, and then you just yank and you pull out the filter. How about this patient? Okay, this patient is a GTX filter. Prior to starting the catheter-directed thrombolysis, it was placed pretty centrally. This is a young man, goes Bali. He's a Japanese, in fact, but then he windsurfs in Bali, which I'm sure what Dr. Anore wants to do. But okay, so he windsurfed. So when he went back to Bali, he didn't listen to our advice to stop physical activity for at least a month or 2 months. Immediately he went back, he felt better with his leg swelling better. He started to go back to his physical activities. Everything moved, as you can see very clearly, that the tip of the filter has tilted now into the right renal vein. And then when we tried to snare it for about 2 hours, of course that didn't work. And then in the end you snare, and you never ever pull the filter out this way, which is on the right hand side. Okay? Never ever do that, because this is called a ragdoll appearance. You never ever pull it, because you're just going to cause more damage. The patient went for an open removal of the IVC filter, and he's doing very, very well. Okay, angioplasty alone, unfortunately, do not provide durable results. This is because in the veins, a lot of the stenosis is from extrinsic compression. And because of the thrombus, it causes a lot of recoil and restenosis with a high residual elastic force of the culprit lesion. With an IVUS, you can see that if you pre and post balloon angioplasty, there's hardly any difference, and you really need to put a balloon up there to make sure that the vessel really opens up for you. Long-term effects, if you with combination of iliac stenting, the patient will do very, very well. Patency rates, as you can see, after 5 years they do really, really very well. But there are some technical considerations as well as you are starting out. Please use big stents. Use the same size as you would in a normal lumen so as to make sure that your veins are adequately decompressed. Okay, the symptoms will persist if your patency is undersized. Okay, despite the stents being patent, if it's undersized. And these are some of the guidelines: 22 mm for IVC, 16 for CIV, 14 and 12 and so forth. Unfortunately, most times you need to extend the stent a little bit into the IVC. Although having said that, with some of the newer stents, which is like they have an oblique cut into the stent, you can prevent that from happening. But this came out only about the last 2 to 3 years. Not everybody use it. You need to stent all the lesions without any skip areas, because the skip areas will result in restenosis and occlusion, and you have to overlap your stents generously. Okay, and sometimes you may need to have a mid-thigh access for infra-inguinal stent extension. So again, this is when you are doing the IVUS tells you the estimated size and the area of the vessels that you want to stent. And because of the elevated peripheral venous disease, you end up with chronic ulcers later on. So again, the message is don't undersize. Okay, if you undersize, this is what happens. Okay. Again, these are some of the venous stents. So the procedure is quite simple. We do this in the hybrid OT, and then at least with anesthetic support, the patient is placed supine. I don't turn the patient around anymore. I learned that from the vascular surgeons, in fact, because you can very, very safely assess the popliteal vein from a medial approach, which is around the level of the upper tibia. Okay, like what the patient's leg is like now. You can, with slightly externally rotated, slightly 45 degrees flex, and you can look for the portal vein under ultrasound guidance from a medial tibial approach. Put in an appropriate size stent. Put in the infusion catheter or the angiojet catheter, and then identify the lesion, balloon angioplasty, and then do the stenting. So this patient, you can very clearly see that the reason why she's compressed is not due to May turners, but rather is due to a huge fibroids. Okay, who will do a UFE at the same sitting? Nobody, yeah. Okay, sometimes you see the fibroid so big, you wonder whether you should do a UFE first. So anyway, you can see from the blue color, that's how squashed your vessels are. But you realize that your arteries never get squashed, no matter how big your mass is. Okay, the arteries never get squashed. I've never seen arteries getting squashed. And this patient obviously has very bad lymphedema on the left side. I mean, very bad subcutaneous edema on the left side. So you can listen to what the medical people want to recommend you, which is to start anticoagulation for 6 months. Okay, but this patient is going to end up like this for, I don't think this patient can even tolerate this for 6 weeks or even 6 days. Okay. So as you can see on the coronal images on the CT, tells you a lot of information. Tells you approximately where the clot is extending to. You can see the filling defect very clearly on the left side. You can estimate the length of the stent that you require. And then you come from where I said the tibia. Then it's very, very easy to just go up with the guide wire and your catheter. It's extremely simple. So remember that your IVC needs to go, you must remember that the wire needs to go across the midline to the right side. If your wire looks like this, you are not in the IVC, okay? You are not in the internal, you are not in the common iliac vein. You are in some iliolumbar vessels, which on this picture tells you very clearly that you are in the wrong place, So if you're in the wrong place, you just need to find the right place. And I can tell you this is extremely, extremely simple for us who muck around with microcatheters. You're dealing with an 035 system. It's extremely simple. You don't get where you want to go initially, just bring your catheter back and then find another lumen. Even if you perforate, so what, big deal, this is really occluded. It's not going to bleed. You don't care. I don't care. Okay? Bring your wire across. On the right side, you get your groin access. You do a gram. You can see very clearly where your occlusion points are from the extrinsic compression. Pulse spray, go up and down as the usual manner. Get rid of as much of the clot as you can. And then finally, when you are done with that and you get a good flow going, you don't have to get perfect flow, as I said. You just need to get some flow going. You don't get perfect flow. You just get some flow going. Then you need to stent. But you cannot put the stent from the popliteal vein because most of these big stents do not have that shaft length. So unfortunately, you will need to puncture the left groin access sometimes to deploy the stent. So after you have, but we have a lot of difficulty going up, but you got a balloon wire up there already. Have your wire just following, buddy it, okay? And then before it, voila, you are actually back in the lumen that you angioplasted rather than in some collaterals. And then after you've done some more gram, telling you very clearly where your level of obstruction is and where you need to stent to. Do your stenting. On the right side is awesome. The flow is great. On the left side, you can see that there is a little bit of pseudostenosis from oversizing of the first stent, and then the vein from the inflow is not so good. That's why it looks so small. Extend, and then you got good inflow. Remember, you can see there's still a little bit of clot in the common femoral vein, just right above the sheath, right at the bottom. Okay, you don't have to worry about that. Those are all chronic clots. No matter how much you angiojet, how much you pulse spray, it's not going to work. This patient needs to be started on anticoagulation anyway. You may want to put the patient on compressing stocking just to encourage the patient to have some increased venous flow. That is just for the purpose of venous flow. It's not because you want to cure the patient of the underlying DVT. So in summary, treat the arteries and the vein different. They're not the same. The history, signs and symptoms are important. Look at all the prior imaging and know what you are trying to achieve. For arteries, always aim for perfection down to the foot. Okay? If it's for vein, your aim is to reduce PTS. Remember the Virchow's tried, get some flow going, prevent endothelial damage, prevent stasis. Catheter directed or PMT is either fine, but it's not for everyone based on current evidence and guidelines. If the patient is young, the patient is healthy, the patient is active, I will go all out and treat these guys. Treat the young clots, and for the lower limb DVT, IVC filter only in very selective patients, okay? Because your pulse thrombolysis, your aspiration will remove a huge clot thrombus load, and what you are trying to achieve, and even if some of the clots fly off, you know and I know none of it really matters. Stents are often necessary, whether it's for the arteries or the venous side, and the trend is therefore now from a multi-session catheter-directed thrombolysis to a single-session treatment. Thank you very much.
Is there any question? Yes.
I saw your venoplasty procedures. I just wonder whether you put because before that you mentioned sometimes we do not need to put a filter in because sometimes it may cause the DVT. But actually, in the case you did the venoplasty intervention, did you place the filter in the IVC?
You're talking about